Yeah. This potential. And you know this meaning of this. It is the R is the gas constant. Suitable unit it is taken to have the millivolt in this case on the left side. And capital T is the absolute temperature. Z is the valence. It is -1 for the chloride ion. And F is Faraday, number of coulombs per mole. This is the capacitance of the membrane. Capacitance. In this concept, and Faraday and chloride ion concentration outside divided by chloride ion concentration inside. In millimole per liter or mole per liter, whatever you may think. At particular temperature. Then an ln is the natural logarithm. Log to the base e. ln is equal to log to the base e. And if it is expressed in base 10 logarithm, common logarithm, it is more than this value. It is 2.003, 2.003. Yeah. And if these values are, numerical values are taken, and the temperature 37 degrees centigrade plus 273 in this way, and it is calculated, and these concentration ratios are taken in this way, then you will get some negative value, and this negative value (61.5), and to remove this negative value, we have inverted the chloride concentration in the logarithm, and it becomes almost equal to that of -70 millivolt in case of an action. So it closely corresponds to that of the resting membrane potential of the action, -70 millivolt. -70 millivolt. Resting membrane potential. So you can imagine that at that condition, there is no active transport across them. And this is derived, and this formula has been derived, considering that the tendency of the ion to move along the concentration gradient and that of the electrical gradient is equal to 0. Whenever there is equilibrium to develop. There is no net movement of the ions. And total is called electrochemical gradient of this ion. It is called mu x. X is any ion in this case. So you can split it, then you can split it. You split this equation. Then this ECl into ZF is equal to RT. You can split it. Here, split it. And if you take, and it is due to this concentration difference. All are explained in energy per mole. energy per mole, and it is the tendency. It is the for this tendency of chloride ion to cross across the membrane following the concentration gradient. Concentration gradient. Not for the chloride ion, any ion, this formula. RTZF multiplied by this potential difference, that is the I minus. You may consider for better understanding. And if you take this value to this value on this side, and you then change this, and it will be mu, and it will be equal to mu chloride. Yeah. And this equation can be solved in this condition. And it is when they are considering that they are equal. They are equal. Equal. It is so it is the non-potential. At membrane potential at which there is no net tendency of the chloride ion from concentration gradient from that is the y to x, and it is equally countered by the electrical gradient to move from x to y. X to y. And this is the primary formula. And from this primary formula, this formula can be derived. If the textbook does not have a space, then you have to reconsider how it is possible. And you get, there are two sets of data on either side. One is due to, and so their sum is equal to 0. And this is the for the concentration difference, and it is for the electrical difference. Electrical difference. It is due to this part is electrical difference, and then they total 0, and you then calculate, you get the ECL, and it is the Nernst potential. So initially it is I minus O, inside minus outside. When we simply calculating, and you can take any value, but whenever at the particular value of a particular cell and at a particular temperature, whenever there is equilibrium, then only Nernst equation is applicable, and you can then this value, and it is the called the equivalent potential of this particular ion. And if this data is then simplified from the base, then natural log to the base 10 log, and the calculated, you will get this type of value. And removing the z from this, that is the minus sign, you get this value. And if you put this, you calculate, it will be minus 70 millivolt or so. When it is equal to resting membrane potential, then you can think there is no forces besides these physical forces is responsible for this. Or if you imagine something that there may be some cellular processes, whatever it may be, when it in the steady state, then it will not vary. It will not vary. If there is change in the chloride ion concentration from outside, then it will rearrange in such a way that the steady state, you will get another value, but that will be following this equation. Following this equation, you will get another steady value. Clear? Now come to the potassium ion. In case of potassium ion, this formula is EK. Then you give a negative sign and potassium concentration inside divided by potassium concentration outside. Outside. because it is the positive value, +1 value, Z is equal to +1. And you get the Ek. And it will become 61.5 log potassium concentration minus 60 potassium concentration inside divided by potassium concentration outside. Suppose this value is 150 and it is 5.5 millimole per liter. Then this value will be, suppose in this case it is minus 90 millivolt. But it is different from the resting membrane potential. Resting membrane potential is close to this value, but exactly do not say. Yeah. So this ion, that is this value, is close to this value, but not exactly the same as in the chloride ion. So you can think there is some excess potassium within the cell. So it will have a tendency to move from this side to this side to make it minus 90 millivolt. Positive charge, therefore minus more negative. It is minus 90 millivolt, but resting membrane potential measured by a cathode ray oscilloscope is minus 70 millivolt. So you can think there is, when you considering that the equilibrium is not established. In case of chloride, this equilibrium is established. But in this condition, it is still further from the equilibrium. Some extra positive charge is clear. So potassium has a tendency, natural tendency to move from inside to outside. And outside its concentration is 5.5 millimole per liter. And it is 150 millimole per liter. From a reliable textbook, we are giving this type of figure. Clear? But in case of sodium ion, it is different. Sodium ion. Then in that case, whatever it may be, that is the negative sign. So sodium ion concentration outside is 150, and suppose it is 15 or so millimole per liter. In the inside it is lower, in the outside is higher. And so it is the sodium ion concentration. Inside, and sodium ion concentration, outside. As there is a minus sign and it is more than this, suppose in this case it is 15, it is 150 or so. 10, then minus, so you can think it is plus 91.5. 61.5. 10 log 10 1, then 61.5. So roughly the value is plus 60 millivolt. And it has the concentration difference also, and also electrical gradient in the same direction. It is a concentration gradient in this direction, and also by the electrical gradient or also in the same direction. So it is far from this resting membrane potential. It is positive sign. It is a positive sign. And it indicates that sodium is very less permeable, and it is factor. Hydrated form of sodium is larger than of potassium ion, and the sodium, that is the voltage gated sodium channels. Voltage gated sodium channels in the resting condition is much less permeable. So what occurs? Only whenever there is change in the membrane potential, then this voltage gated sodium channel will open, and then the sodium has a scope to enter into the cell. Following it, a concentration gradient and electrical gradient, and it will try to bring to this plus 60 millivolt at 37 degrees centigrade. Yeah. And then whenever there is action potential generation, it becomes, inside becomes positive. And so the membrane potential at that situation, at that point of time, then it becomes positive. Yeah. So this behavior of this membrane will determine this. So it will depend upon the, there is the permeability or conductivity, almost the same, and the behavior of the channels. When numerous ions are, at least 3 ions you are considered, those are important in this case: sodium ion, potassium ion, and chloride ion. There are equations by means of which their contribution regarding the permeability and their concentration is also considered. Goldman constant field equation you will find in your text. Goldman constant field equation, they take into consideration of the contribution of the all ions. This permeability are also taken into account. মানে তাদের ভেদ্যতাকেও এখানে গণ্য করা হয়েছে, এবং তাদের কনসেন্ট্রেশন মানে তাদের পরস্পর যে ঘনত্ব সেটাও আমরা এখানে করা হয়েছে। গোল্ডম্যান কনস্ট্যান্ট ফিল্ড ইকুয়েশন, and this formula is given in the text, and it is like this. PNA, sodium concentration outside, plus PK, potassium concentration, plus chloride concentration, chloride PCl into chloride concentration inside, divided by PNA, sodium concentration inside, and potassium permeability into potassium concentration inside, plus PCl, chloride concentration outside, reverse of this due to charge difference, and it is Goldman constant field equation. And from this, if this is value is less, so the contribution of this is more important. So potassium is the primarily responsible from the membrane potential. It is primarily the diffusion potential, and this effect is due to this Donan effect, because within the cells there are some charged anions, protein anions, phosphate anions, and they cannot traverse across the membrane, and when the membrane is selectively permeable, it will some ions to pass through easily, but not others. And so this behavior of the channels, and these ions will take to bring the membrane potential to its favor. Yeah. And more permeabilities and more its contribution. বুঝা গেল? এজন্য এটা হচ্ছে another is the chord conductance equation. And in that case, the same thing is there. And in that case, that is the EM is equal to, that is this Suppose Gk divided by delta G into Ek. Sigma G in this. So it is the weighted average, and in that case, it is this equivalent. It is the denominator is equivalent to plus of this. So this plus GNA plus GCL. It is a weighted average, and it is their electric potential. And if you take EM minus GK in this case, and consider that net movement is 0, and then formula can be derived. Chord conductance equation, and from which the same thing is evident. More permeable the ion is, more its contribution to the membrane potential. Yeah. So this is something about the donor equilibrium, and also the Nernst equilibrium potential, and also this type of, there is the also this how they are influence the resting membrane potential. And concentration of the ions are not exactly similar in all the structures. Their concentration in the muscle is to some extent different from the nerve, and their permeability is also different. And for this reason, there is different resting membrane potentials. But it is not a fixed value. In course of activity, this value is changed. It may be depolarized, that is, it becomes less negative, or it may be hyperpolarized in some condition, then it will be more negative. Yeah. And in considering these ions and their properties, there is patch clamp technique is there, patch clamp technique. And it is also important, patch clamp technique. Patch clamp technique. By means of which the behavior of these channels and that had been known. And how it is possible? A microelectrodes are generated. They are very small lumen diameter at their termination, and they can be placed over the cell membrane, and there can be penetrate the cell membrane, and some suction effect may be done to them. And in this way, this and at the luminal site, only a few ion channels it can accommodate, and by means and their behavior can be known. Either spontaneous or by induced, their behavior can be known. Suppose a patch clamp is taken in such a way that it is this an ion channel is there, and the electrode, it is a cell is intact. The cell is intact, and in this way, its behavior can be known. It is the cell attached patch clamp. Cell attached patch clamp. That is at this luminal surface, and there is a single, in this case, it is a single ion channel, or it may be more. For simplicity, cell attached patch clamp, and it is the electrode. It is the electrode. And this recording electrical events can be known. It may be spontaneous or it may be induced. Suppose in case of spontaneous, you will get it is millivolt, and it is closed, and it is the of a particular ion. This can be recorded. The behavior of the channel. Yeah. Or there is the, and it is possible to make that is, this is disrupted. It is inside out. It is inside out. It is ruptured, cell is ruptured. So this, it is this inside side, it is outside side, and it is the electrode. And this type of inside out patch clamp technique. Or it is possible to suck up this so that this it will enter directly into the cell, whole cell recording. And in that way, it is possible that cell is there, but it is ruptured in such a way that is sucked up, and that through and through connection, it is the ICF. It is the whole cell recording. It is the whole cell recording. Whole cell recording. So in this way, the different conditions, their membrane potential, inside what is the potential also. It is the patch clamp technique. Details are given in different texts. It is the basic thing. It should be mentioned along with this. How this behavior can be known. Sodium channels, they have voltage gated channels. They open and then quickly becomes inactivated. Potassium channels, they will open and for considerable time. So their behavior is also different. And that has been known by the patch clamp techniques. Now there are generation of the action potential. Action potential, that is the potential change that is abrupt. And it will propagate along the action. And the stimulus may be threshold or sub-threshold. And in that case, you are considering that is the stimulus is given, electrical stimulus is given, and it is a square type of, or rectangular type of pulses. Rectangular type of pulses. Rectangular. It has a fixed duration. Amplitude indicates the strength. The duration is fixed. Duration fixed. Suppose it is the different levels of sub-threshold, and it is the threshold level. They are the sub-threshold, and it is the supra-threshold type of strength. It is the strength or voltage, and it is the duration in time, millisecond or so. They are, this type of rectangular type of voltage is given. And the behavior of this membrane of different cells can be known. It may be sub-threshold, and when it is, then there is action potential generation. And during the action potential generation, inside may be positive, and it will propagate. So details of the action potential we can discuss in another class, and in this way we should enter into the physiology of the nerves and then physiology of the muscles, and there will be continuity. And these are very easy chapters. I request you to go through the book, and when you go through the book, you will find my deficiencies also, and also your knowledge will be permanent. And if you find some difficulty, then you may contact me in suitable time. Yeah. I think it is all for today. And it is your duty to go through books and have some knowledge. From next day, action potential and related topics we will discuss. And gradually we will enter into the physiology of the nerves and also then physiology of muscles of also. Thank you.
So this is the palmar space, already you know. This is the mid thenar space, is the mid palmar space. And this is the palmar aponeurosis. So it is the anterior posterior boundary. This palmar space, anterior boundary, this structure, flexor digitorum profundus and superficialis with the third and fourth finger, and posteriorly this is the lumbricals and interosseous, and so on and so forth. But what is this proximal and distal boundary? That is more important. Proximal and distal boundary. It is the, I have drawn it, it is the cut section in this fashion. So you see the ventral boundary and the dorsal boundary, or in anatomical position, it is the anterior boundary and the posterior boundary. But what is the extension and the surgical approach? Suppose there is an infection here, there is an infection here, an infection usually extend, খুব বড় হয়ে গেছে infection, pus, full of pus, and flexor digitorum superficialis become and full of pus, and there is a tendency of you as a new doctor, there is a pus, so there is a swelling here, so I will incise this and pus will drain out. Yes, it will drain out, but I have already told you there is a chance of contracture. This palmar aponeurosis will be cut, and this palmar aponeurosis will be healed by fibrosis, and there may be, not always, there may be deuterance contracture. So, what is the ideal approach of draining this pus? To know this, you have to know the proximal and distal extension of this palmar space. তাহলে আমরা এই ছবিটা আঁকি। So this is the thinner space, this is the flexor retiniculum. And this is the back to it. This is the mid palmar space, this is the thenar space, which is separated by a intermediate septum. So this is the septum when you view antero-posteriorly, proximo-distally, upper and below. So this is the mid palmar space, and this is the thenar space. Proximally, this is the proximal side, and fingerer dikte hocche distal side. Proximally, the space is closed. Proximally, the space is closed by attachment with this undersurface of the flexor retiniculum. Both this space, it is closed. But distally, it is extended into the waves of the finger to a proximally, the mid palmar space extend into the two extension finger-like projection we call the lumbrical canal, because this canal is by the side of the lumbrical, around the lumbrical muscle. And ultimately, it goes to the wave space. এটাকে বলে wave space, এই যে। So, mid palmar space extend into the wave spaces of the fourth and fifth and third and fourth finger. Similarly, thenar space extend into the first and second and third finger. ক্লিয়ার হয়েছে? ক্লিয়ার? ক্লিয়ার হয়েছে তো? বলো না বুঝতে পারলে। এই স্পেসটা এইদিকে ক্লোজড। কেন ক্লোজড? আন্ডার সারফেস অফ দ্য ফ্লেক্সার রেটিকুলাম এটা লেগে যাচ্ছে। বাট distally it extend as a projection to the waist space and এই প্রজেকশনটাকে বলা হয় lumbrical canal. So this is the total boundary of the palmar space. Anteroposterior বললাম, আগের ক্লাসে বলেছি, anterior boundary, posterior boundary, proximal boundary it is closed, distal boundary extends as a lumbrical canal to the waist space. So you can know if there is an infection here or here, you can easily drain the infection by cutting incising the skin and this in the web space here. So the pus will be drained out. Or in the thinner space, second and third, but dutoi kete dilam and easily drain out. There is a no chance of deep uterine contracture, কোনো স্কার মার্কসও দেখা যাবে না, এই জায়গাটা শুধু কেটে দেব। হুরুর একটা আর্টারি ফোর্সেপ ঢুকিয়ে স্পেসটাকে ঘেটে দেব and pus will come out. No chance of injury to anything, no nerve, no vessels, no palmar aponeurosis. So ideal approach to drain the infection which is common in the mid palmar space or ulnar space, the incising the skin of the approach to the web spaces. In case of a mid palmar space, third and fourth, and in palm first and second waves. তার জন্যই হচ্ছে বলা হলো। এরপরে হচ্ছে আরেকটা ব্যাপার, এবার লাস্ট what is space of What is space of Perona? Space of Perona is a এখানে যেরকম স্পেস রয়েছে, potential space present in the forearm. Present in the forearm. কার কার মধ্যে? Superficial and deep muscles. এইখানে আমরা জানি superficial and partly intermediate and deep muscle. Superficial muscle গুলি কি কি? Flexor carpi radialis, palmaris longus, pronator teres and flexor digitorum superficialis. Intermediate compartment এ flexor digitorum profundus আর deep আছে pronator quadratus. এই স্পেসটা কোথায়? In between the anteriorly flexor digitorum superficialis and profundus. যদি ফোরআর্মের কাটসে এই হয়, আমরা যদি লোয়ার জায়গায় এই জায়গাটা কাটি, এইটা হচ্ছে ফ্লেক্সর ডিজিটোরাম সুপারফিশিয়ালিস অ্যান্ড ফ্লেক্সর ডিজিটোরাম প্রফান্ডাস এর টেন্ডন, আর নিচে রয়েছে দুটো বোনকে কানেক্ট করছে কে? ইন্টারঅসিয়াস মেমব্রেন। তার এইখানটায় লেগে রয়েছে প্রোনেটার কোয়াড্রেটাস। এটা হচ্ছে ফ্লেক্সর ডিজিটোরাম সুপারফিশিয়ালিস অ্যান্ড ফ্লেক্সর ডিজিটোরাম প্রফান্ডাস, আর স্পেস এইটা হচ্ছে প্রোনেটার কোয়াড্রেটাস, আর স্পেসটা রয়েছে এইখানটায়। আবার এটা বাউন্ডারিটা কি? অ্যান্টেরিয়ার পস্টেরিয়ার কাট সেকশন করেছি এরম ভাবে। সো পেরোনা স্পেস ইজ এ intermuscular potential space bounded anteriorly by the flexor digitorum superficialis and profundus and posteriorly by the pronator quadratus and the interosseous membrane. Pronator quadratus তো আর এইটুকুনি মাসল, বাকিটা কভার করছে কে? interosseous membrane. এটার এক্সটেন্ড কোথা থেকে? ফ্রম দ্য ফ্লেক্সর রেটিনিকুলাম আপ টু the oblique origin of the flexure digitorum superficialis. Flexure digitorum superficialis এর origin জানো? এরকম। এটা যদি মিডিয়াল সাইড হয়, এটা ফ্লেক্সার ডিজিটোরিয়াম এইরকম ভাবে অরিজিন নেয়, একটা অবলিক অরিজিন। এই যে এটা বলা হয় অবলিক, এইরকম ভাবে ফ্লেক্সার ডিজিটোরিয়াম সুপারফিশিয়ালিস অরিজিন নেয়। এই স্পেস অফ পেরোনা এক্সটেন্ড প্রক্সিমালি আপ টু দ্য অবলিক অরিজিন অফ দ্য ফ্লেক্সার ডিজিটোরিয়াম সুপারফিশিয়ালিস। সুতরাং স্পেসটা হচ্ছে এত বড়। ফ্লেক্সার রেটিনিকুলাম ডিস্টালি অ্যান্ড অবলিক অরিজিনটা রয়েছে এইখানটায়, এতটা বড়। কার কার মধ্যে? বিটুইন ফ্লেক্সার ডিজিটোরিয়াম সুপারফিশিয়ালিস অ্যান্ড প্রফান্ডাস এর মধ্যে। আর নিচে কে আছে? প্রোনোটার, কোয়াড্রেটাস আর ইন্টারঅসিয়াস মেমব্রেন। এত কথা বলছি কেন? পেশেন্ট তোমার কাছে একটা সোয়েলিং নিয়ে এলো এইখানটায়, পাস ভালো করে দেখতে পাচ্ছ সোয়েলিং, you give antibiotic. If it is okay by antibiotic, okay, but there is a no relief, then what have to do? In surgery there is an one word, when there is an pus you must get away, মানে পাস যখনই থাকবে ড্রেন করতে হবে। কিন্তু এখন এত ভালো অ্যান্টিবায়োটিক বেরিয়েছে, so many good antibiotics are there, sometimes it doesn't hold good, the antibiotic may act, but usually dictum is that whenever there is an pus you must drain it out. এটা হচ্ছে নর্মাল ডিকটাম অফ সার্জারি। সার্জারিতে যখন যাবে এই কথাটা বলবে। তাহলে এখানে পাস আছে, আমাকে ড্রেন করতে হতে পারে। ড্রেন করে দিলে কোথা দিয়ে ড্রেন করব? ল্যাটারাল ইনসেশন দেওয়া হয়, এই দিক দিয়ে ল্যাটারাল ইনসেশন দেওয়া হয়। কেন? নট টু ড্যামেজ দ্য নার্ভস অ্যান্ড ভেসেলস অ্যান্ড দ্য মাসেল। এই ল্যাটারাল বর্ডার অফ ফোরাম দিয়ে ড্রেন করি, এখান দিয়ে ইনসেশন দিলাম, এরপরে একটা আর্টারি ফরসেপ দিয়ে ফাঁক করে দিলে পাস বেরিয়ে এলো। ভালো কথা, পাস বেরিয়ে এলো। আবার কিছুক্ষণ পরে পেশেন্ট আসছে, আবার পাস। কেন কি? এইখানটায় কিন্তু সোর্স নয়, সোর্স ছিল এইখানটায়। কোথায়? লিটল ফিঙ্গার একটা নিডল ঢুকিয়ে অ্যাবসেস হয়েছে, সেই থেকে এখানে চলে এলো। হাউ? আলনার বার্সা তো আমি আগে বলেছি, আলনার বার্সার এক্সটেন্ট হচ্ছে এত অবধি। এটা যদি আলনার হয় 2.5 সেন্টি, খুব সুন্দর বলেছো। এটা হচ্ছে আলনার বার্সার এক্সটেনশন 2.5 সেন্টিমিটার প্রক্সিমাল আপ টু, এইটা যদি আলনার বার্সা হয়, ধরে নিচ্ছে এটা আলনার বার্সা, এই এত অবধি হচ্ছে এক্সটেন্ড। আর স্পেস অফ পেরোনা হচ্ছে এখান দিয়ে শুরু আপ টু দ্য অবলিক অরিজিন, সরি এটা এরকম ভাবে আর কি। এটা হচ্ছে আলনার বার্সা। আর এটা হচ্ছে স্পেস অফ প্যারোনা। বুঝতে পেরেছো? ফোর আর্মে ব্যাপারটা কিছুই নয়। এইখানে পাস হয়েছিল অ্যান্ড এটাকে ফাটিয়ে দিয়েছে, অ্যান্ড পাস গেট সেন্ট্রি। এত পাস হয়েছিল, এই যে আলনার বার্সা থিন মেমব্রেনটাকে ফাটিয়ে দিয়েছে পাস, এবং তার ফলে পাস এখানে যে লিটল ফিঙ্গারে যে পাস, এই যে আলনার বার্সা, এই আলনার বার্সার এইভাবে এইভাবে গিয়ে এই দিকে ঢুকে গেছে, বা রেডিয়াল বার্সার এখানে ঢুকে গেছে। সুতরাং তোমাকে এইটাকে যেমন ড্রেন করতে হবে, এই জায়গাটাকেও ঠিক করতে হবে। আল্ট্রাসাউন্ড করেই বোঝা যায় আজকালকার যুগে। সুতরাং এবার হচ্ছে আমাদের কি কোশ্চেন দিতে পারে, দেয়ার ইজ এন পিন প্রিক in the little finger and there is an pulse space infection in the little finger, but patient complained of a pus in the forearm. How? তখন বলতে হবে এইটা। এরপরে আরেকটা কি এখন বললাম? পালস স্পেস। তাহলে লাস্টে আমরা জানবো হোয়াট ইজ পালস স্পেস। এগুলি কিন্তু মোর ইম্পর্টেন্ট ক্লিনিক্যালি। সব পেশেন্ট আসবে না, সব পেশেন্ট তো কোয়াকরাও ঠিক করে দেয়। কোয়াক ডক্টররাও 80% normal patient they can cure, but 20% needs MBBS, and it is one of them. So তোমরা যদি MBBS, you have to prove yourself that as MBBS knowing this. Meningitis comes with initially like a cold, common cold in children, coughing, sneezing, running water. And normal common cold also, coughing, sneezing, running water. But quack cannot diagnose meningitis. But you can diagnose in between these two patients, this patient is meningitis and this patient is a common cold. By knowing and by examining the anterior frontanelli, neck rigidity, Carnick sign. There are so many signs here, there you can see. That is the difference between a quack doctor and an MBBS doctor. A quack doctor simply drain in this fashion and you will drain in this fashion. That is the difference. এটার জন্যই আমি স্ট্রেস দিচ্ছি এগুলিতে। সবকিছু পরীক্ষার জন্য না, পরীক্ষাও আসবে এটা, কিন্তু এটা একদম গেঁথে নেবে। শুধু মুধু রেফার করে লাভ নেই। এটা জেনারেল প্র্যাকটিসে বসেছো, সব পেশেন্টই যদি সার্জারিতে রেফার করে দাও তাহলে তোমার থাকবে কি? If you refer all the patients to a specialist, then what will you do? You can easily manage your outdoor or in your chamber by simply doing this. Incises, drain out pus, compress bandage, antibiotic and give away. Patient will be okay. Next is the pulse space. এটা কি বোন? মেটাকার্পাল, প্রক্সিমাল ফ্যালেংস, মিডিল ফ্যালেংস, ডিস্টাল ফ্যালেংস of these fingers. থাম্বের ক্ষেত্রে হলে কি হবে? মিডিল ফ্যালেংস will be absent. Proximal and distal phalanx. আমি আর থাম্ব আঁকছি না। This is the flexor digitorum profundus tendon inserted here. And this is the flexor digitorum superficialis tendon splits and inserted in the middle phalanx. Right? ঠিক বলেছি তো? হ্যাঁ? বারবার আঁকছি কিন্তু flexor digitorum superficialis profundus এর টেন্ডনের ইনসারশন বোঝানোর জন্য। And this is the skin. This is the nail bed. In the terminal phalanx, in between the skin and the bone, there is সবখানটাতেই আছে, and onto the every phalanx there is an fibrous septa partition from the skin to the bone. And this contains fat, superficial nerves and blood vessels. This and the space between the bones and the skin we call pulse space. Especially along the terminal phalanx. এটাকে আমরা পাল্প বলি। সুতরাং pulse space is a space between the skin and the terminal phalanx, which is compartmentalized by number of fibrous septa, which is এখানটায় প্রচুর ফাইন নার্ভস রয়েছে and blood vessel রয়েছে। ব্লাড ভেসেলটা কিভাবে রয়েছে সেটা আসছি আমি। তাহলে এটা হচ্ছে পালস স্পেস, এই জায়গাটা ক্লিয়ার হয়েছে? এই যে এইটা, এই জায়গাটাকে বলা হয় পালস স্পেস। এটাকেও পালস স্পেস বলে, কিন্তু আমরা এটাকে বলি কেন? দেয়ার ইজ এন স্পেশাল ইন সুইং নিডল or some fine works, there is a chance of injury of the skin of this terminal phalanx. So when there is an injury, bacteria can grow and produce infection and pus formation. পুজ জমে গেল, and we call it Whitlow. In general term, pulse space infection, in general term, we call it Whitlow. What is the most important part? Number one, দুটো importance আছে, as it is very common. Number two, it is very painful. Very painful. এইখানে একটা ইনফেকশন হচ্ছে, অত পেইনফুল নয়, কিন্তু এইখানে একটু হলেই খুব দেখবে পেইন হচ্ছে। কেন? ওয়াই? বিকজ ডিউ টু দিস ফাইব্রাস সেপ্টা, এখানে যে পাস জমা পড়লো, ইট ক্যানট স্প্রেড। ইট ক্যানট স্প্রেড, ছড়িয়ে যেতে পারে না। অ্যাকর্ডিং টু ফিজিক্স, যত ছড়িয়ে যাবে টোটাল প্রেশার এক্সারশন কম হবে। ফলে একটা স্মল এরিয়াতে এই পাসটা এখানে প্রেশার দিচ্ছে, চারপাশে প্রেশার ক্রিয়েট করছে, আর এইখানে রয়েছে সো মেনি নার্ভস। সো নার্ভকে সে ইরিটেট করে যাচ্ছে, and this nerve, irritating nerve causing pain. So pulse space infection is a very painful condition. In neglected cases, there is a chance of simple this pulse space infection. In neglected cases, there is a necrosis. Necrosis means ki death. Death of the distal 3/4 of this terminal phalanx. Dangerous thing. Bones ta noshto hoye jabe. Why not proximal 1/4? হ্যাঁ, মানে কিসের জন্য আমি এই কথাটা বলছি? পালস স্পেস ইনফেকশন হয়েছে, নেগলেক্টেড হয়েছে, অ্যান্টিবায়োটিক যে দিয়েছে, কোয়াক দিয়েছে, কাজ করেনি। কেমন? ট্যাক্সিম দিয়েছে, ভালো কাজ করেনি। ও ভাবছে ট্যাক্সিম ওটা এখানে খুব ভালো কাজ করবে, কিন্তু স্ট্যাফাইলোকক্কাল ইনফেকশনে ট্যাক্সিমও ভালো কাজ করবে না, কাজ করলো না। সেফেক্সিম আর কি আমি বলছি, ট্রেড নাম বলাটা উচিত হয়নি। হ্যাঁ, সুতরাং কেন তাহলে এরপরে নেগলেক্টেড হয়ে গেল কেসটা। সুতরাং দেয়ার ইজ এন, কিছুদিন পরে পেশেন্ট দেখলো যে অসম্ভব ব্যথা করছে এবং জায়গাটা কালো হয়ে গেছে। তুমি এক্সরে করলে দেখলে গেছে, কিন্তু এই জায়গাটা বেঁচে আছে। Base of the proximal phalanx living, but this is necrosed, ধ্বংস হয়ে গেছে। Why? Very good, ঠিক বলেছে। So any necrosis is usually due to whatever it may be, is due to lack of blood supply, lack of arterial supply. যখন নেক্রোসিস হয় তার মেইন কারণ, সেটা হার্ট হোক, বোনস হোক, মেইন হচ্ছে আর্টারিয়াল সাপ্লাই ল্যাক, অ্যাবসেন্ট, অবস্ট্রাকশন। এরপরে বলো বলো, অতটা নয়, সবই ঠিকঠাকই যাচ্ছে, একটুখানি ট্রিকি ব্যাপার আছে, সেটা আমি বলে দিই। ঠিকই বলছো। এই যে ওয়াই, কালকে ক্লাসে বলেছিলাম তোমাদের সাথে, আর্টস স্টুডেন্ট এবং সায়েন্স স্টুডেন্টের তফাৎ হচ্ছে কি, আর্টস স্টুডেন্টের মধ্যে ওয়াই জিনিসটা কম, কিন্তু সায়েন্স স্টুডেন্টের মধ্যে ওয়াই ওয়াই ওয়াই, কেন কেন এটা হবে, কেন হচ্ছে, কেন সূর্য উঠছে পূর্ব দিকে, এই জিনিসটাই হচ্ছে সায়েন্স। যখনই ওয়াই আসবে জানবে ইউ আর এ সায়েন্স স্টুডেন্ট। যাকে এই যে ডিজিটাল আর্টারি, এই যে সুপারফিশিয়াল পামার আর্ট বা ডিপ পামার আর্ট থেকে বেরিয়েছিল ডিজিটাল আর্টারি, এইটাকে এইরকম ভাবে সেপ্টার মধ্যে দিয়ে গিয়ে এই সাপ্লাই করছে বোনকে। এরপরে যে প্রক্সিমাল পার্ট অফ দ্য বোন, it has got a separate supply, and separately it supply the proximal part. So there is an, in addition this supply, proximal part also get a separate supply just beyond the flexor digitorum superficial. কেমন? সুতরাং যখন ইনফেকশন হচ্ছে এই আর্টারিটা কম্প্রেস হয়ে যাচ্ছে, সো ল্যাক অফ ব্লাড সাপ্লাই টু দিস ডিস্টাল পার্ট। কিন্তু এই আর্টারিটা মোর ডিপে থাকছে এবং জাস্ট মিডিল ফ্যালেন্সের পাশ ওপর দিয়ে আসছে বলে দিস আর্টারি, দ্য সেপারেট ব্লাড সাপ্লাই ইজ নট ড্যামেজড। সো প্রক্সিমাল পার্ট অফ দ্য ডিস্টাল ফ্যালেন্স হ্যাজ গট এ সেপারেট অ্যাডিশনাল ব্লাড সাপ্লাই সো দ্যাট ইট ইজ সেভড। এটা বেঁচে গেল। এই আর্টারিটা ড্যামেজ হয়, এই যে সুপারফিশিয়াল ব্রাঞ্চটা ড্যামেজ হয় এবং তার ফলে এই ব্লাড সাপ্লাই পায় না, দিস ইজ ড্যামেজ। কিন্তু এই আর্টারিটা ড্যামেজ হয় না, তার ফলে প্রক্সিমাল পার্ট ইজ সেভড। সুতরাং এখান থেকে একটা অনেক সময়ই এক্সপ্লেন হোয়াই কোশ্চেন দেয়। তাহলে এইটা আমাদের এটা হয়ে গেল। নেক্সট লাস্ট 2 minutes the last part of the superior extremity অনেক সময় এখনকার দিনে দিচ্ছে ডরসাল ডিজিটাল এক্সপানশন, যেটা আমরা পড়ি না, বাট সামটাইমস দ্য শর্ট নোট মে কাম। হোয়াট ইজ ডরসাল ডিজিটাল এক্সপানশন? আমি তোমাদের তৈরি করছি যাতে শর্ট নোট একদম একটাও যাতে মিস না হয়, যেখান থেকেই দিক ইউ ক্যান ডু। Metacarpal, proximal, medial and distal phalanx. There is a muscle in the dorsum known as the extensor digitorum, which takes origin from the common extension tendon origin from the medial lateral medial epicondyle. Then, lateral epicondyle. Then extensor digitorum combine comes to the hand under the extensor retinaculum. এইখানে যেমন ফ্লেক্সর রেটিনিকুলামে দিয়ে গেছিল, এইখানেও আরেকটা রেটিনিকুলাম আছে, ঠিক এরকম তাকে বলা হয় there it is called extensor retinaculum. What is called? Extensor retinaculum, and under the extensor retinaculum all the extension passes. And very important question, the tendons on the base of the radius and head of the ulna, মানে এই জায়গাটায় কি কি টেন্ডন কিভাবে পাস করে, কোন কোন কম্পার্টমেন্টে, অ্যাবডাক্টর পলিসিস লঙ্গাস, এক্সটেন্সর পলিসিস ব্রভিস, এক্সটেন্সর পলিসিস লঙ্গাস, এরকম ভাবে বলতে হবে, এক্সটেন্সর ডিজিটোরাম, এক্সটেন্সর ইন্ডিসিস, এক্সটেন্সর ডিজিটি মিনিমি, এক্সটেন্সর কার্পি আলনারিস, এরকম ভাবে সব বলতে হবে। কোন কোন কম্পার্টমেন্ট, 6টা কম্পার্টমেন্ট আছে, and what are the tendons passing through these 6 compartments in the dorsum of the wrist. Very very important. আচ্ছা, এই এক্সটেন্সর ডিজিটোরাম টেন্ডন এখান দিয়ে আসে, হ্যান্ডসে ঢুকলো এবং এই জায়গাটায় it become expanded, sorry এটা মিডিলে হলো না, এটা এখানে আরেকটা করছে, আরেকটা ফিঙ্গারও ঠিক এরকম হচ্ছে, কেমন এরকম ভাবে 4টে ফিঙ্গার, মিডিয়াল ফিঙ্গারে 4টে extensor digitorum tendons আছে। Extensor digitorum tendons here divided into 4 and passing through the extensor aspect of the index, middle, ring and little finger. Index finger এ দেখি কে বলবে, extensor finger এ, so we call it the tendon of the extensor digitorum to the index finger, tendon of the extensor digitorum profundus of the middle finger, tendon of the extensor digitorum to the ring finger, tendon of the extensor digitorum of the little finger. ভালো কথা। এবার বলে ইন্ডেক্স ফিঙ্গারে it is joined by another tendon, extensor indicis, little ফিঙ্গারে extensor digiti minimi. Very good, খুব ভালো পড়ছো, ঠিক, যাকে ওটা যাচ্ছি না। এই extensor digitorum এই প্রক্সিমাল ফ্যালেন্সের বেসে গিয়ে it become expanded by a triangular shaped structure. টেন্ডিনাস, টেন্ডনটা ফ্ল্যাট হয়ে যায়, ফাইব্রাস হয়ে যায়, টেন্ডন ও ফাইব্রাস টিস্যু বিকাম ফ্ল্যাটেন, অ্যান্ড এটা কিরকম হয়, টেন্ডিনাস, এই সরি ফ্ল্যাটেন ট্রায়াঙ্গুলার, ট্রায়াঙ্গুলারটা কিরকম হয়, এই রকম। আমরা দেখতে পাচ্ছি না, এরকম ট্রায়াঙ্গুলার হয়ে যায়। কেমন? ফ্ল্যাটেন্ড হয়ে যায়, এই জায়গাটায় থাকে। তাকে বলা হয় ডরসাল ডিজিটাল এক্সপানশন। ডরসাল ডিজিটাল এক্সপানশন। এই ডরসাল ডিজিটাল এক্সপানশন বেস অফ দ্য প্রক্সিমাল ফ্যালাংসের কাছে গিয়ে ইট ট্রাইফার্কেটস মানে কি? তিনটে, ঠিক এরকম, মিডল ব্যান্ড এবং টু ল্যাটারাল ব্যান্ডস। So it trifurcates into two lateral bands and a middle band. The middle band is inserted into the base of the middle phalanx, and two lateral band goes by the side of the middle phalanx and join again to be inserted into the base of the distal phalanx. তাহলে কি রকম হলো? This is the dorsal digitorum expansion, this is the base, this is the apex, triangular. So it is expanded, and this part we call the dorsal digital expansion. This dorsal digital expansion, how does it insert it? How does it insert? It trifurcates into one medial band and two lateral bands. The one medial band attached to the dorsal aspect of the base of the middle phalanx, and two lateral bands again joined together to be inserted into the base of the terminal phalanx. এরপরে যেটা হচ্ছে, এই ডরসাল ডিজিটাল এক্সপানশনে এই জায়গাটা একটা লিগামেন্ট থাকে, তাকে বলা হয় ডিপ মেটাকার্পাল লিগামেন্ট। দরকার নেই। A lateral part of the dorsal digital expansion is inserted the palmar interossei, dorsal interossei and lumbricals. এই যে এখানে আমরা দেখেছিলাম palmar interossei, এখানে রয়েছে dorsal interossei and lumbrical muscle. So lumbrical muscle is inserted here, and palmar and dorsal interossei are inserted here. So proximally inserted the palmar and dorsal interossei, and distally inserted the lumbricals. তাহলে lumbricals and interossei insertion হচ্ছে in the dorsal digital expansion. এবং এইগুলি ডানার মতো আছে বলে এইগুলিকে বলা হয় উইং টেন্ডন, ডানা টেন্ডন, উইং টেন্ডন. These are called wing tendons. So what are the wing tendons? Interossei and lumbricals muscle, as it looks like a wing to the dorsal digital expansion. Function key? Function of these lumbrical interossei is the flexion of the metacarpophalangeal joint and extension of the interphalangeal joint. আর extensor digitorum এর main function হচ্ছে extension of the terminal phalanx and prolonged by the proximal interphalangeal and metacarpophalangeal jointed extension. অনেক সময় dorsal digital expansion short note দিতে পারে, তাই সেটা বলে দিলাম. So here we end all the chapters, possibly cover all the chapters of the superior extremity. Now we go to the today's is the thorax. So what is thorax? Obviously you know, thorax start from here up to the diaphragm. Above it is bounded by the superior thoracic aperture, and inferiorly it is bounded by the inferior thoracic aperture. Thorax, just আজকে introduction করছি, কালকে থেকে mediastinum যাব, টাইম নেই. This thorax is mainly the pivot, or the main structure of the thorax is the bony. We call it thoracic cage. We call it thoracic cage, which consists of vertebra, ribs and sternum. Vertebra, ribs and sternum. Clavicle is a part of the superior extremity. So it consists of a vertebra, ribs and sternum. Posteriorly, there is a vertebra. We call it thoracic vertebra. So the thoracic cage posterior boundary hoche thoracic vertebra. How many? 12. Numbered from above below T1, thoracic 1, T2, thoracic 2, so on and so forth. Anteriorly, it is bounded by the sternum. Sternum has got a three part. Above, manubrium sterni. This is the body, and lower part is the known as the xiphisternum. And it has got a joint, manubriosternal joint and sternal joint. A manubriosternal joint is very much prominent in male. We call it sternal angle. We call it sternal angle. Laterally, it is bounded by 12 pair of ribs, starting from the first rib above, second, third, fourth, fifth, sixth, seventh, eighth, ninth, 10th, 11th, 12th, of which first to seventh rib, first rib, second rib, third rib, fourth rib, fifth rib, sixth rib and seventh rib is connected by the sternum, the lateral edge of the sternum, by means of a cartilage, directly cartilage. Each rib has got its own cartilage, which it attached to the sternum. First rib has got a first costal cartilage attached to the manubrium sternum. Second rib has got a cartilage attached to the sternal angle. Very important. Very important. The second rib attached to the sternal angle. And this is very important for counting ribs. Counting ribs is not very easy. Because sometimes if you count it from below, the 12th rib is here, it ends. Number one. And number two, in many here, the 12th rib, one on either side, may be absent. Even the 11th and 12th rib may be absent in some person in one side. So if you count it from below, there is a chance of miscalculation. What you think is the 11th, 12th rib, it is actually 11th rib. So, rib counting is always done from the sternal angle. এই sternal angle feel করলাম, যে ribটা গেলাম, it is the second rib. Rib counting এর নিয়ম হচ্ছে, এই আমি sternal angle পেলাম, একটু laterally গেলাম, এই ribটা পেলাম, this is the second rib. Then third, then আর আস্তে আস্তে laterally যাব, কারণ এগুলি ছোট হয়ে যাচ্ছে, fourth, fifth, sixth, seventh, eighth, ninth, 10th, 11, 12 খুব একটা বোঝা যায় না. So rib counting usually done from the sternal angle. So that is clinically it is important. So আগে কি বললাম? First rib to seventh rib has got its own cartilage to attach to the sternum individually. But 8th, 9th and 10th ribs, 8th, 9th and 10th ribs, one on either side, not directly attached to the sternum. They have got their own cartilage, and these cartilage ultimately joins with the seventh cartilage, and via the seventh costal cartilage it attaches to the sternum. বুঝতে পেরেছো? First rib, first costal cartilage attached to the manubrium sterni. Second rib, second costal cartilage attached to the sternal angle. Third rib, its own third costal cartilage attached to the body of the sternum. Fourth rib directly, fifth rib directly, sixth rib in its own cartilage, seventh rib directly attached to the sternum by its own cartilage. But 8th, 9th and 10th, 8th, 9th and 10th have their cartilage. They don't attach to the sternum. Look, it attaches to the seventh costal cartilage, and via the seventh costal cartilage, they are attached to the sternum, Zippy sternum. And 11th and 12th ribs never attach to the sternum. They have got their cartilage, costal cartilage, but very small. And তার মানে এই নয় যে ওদের costal cartilage নেই, they have got, but there remains such. এইখানটায় costal cartilage আছে, but they remain floats. 11th and 12th ribs. So they are called the floating ribs. They are called the floating ribs. Come on. So first two তোমাদের পরে পড়বে, আর ডিটেলসে যাচ্ছি না, ভার্টিব্রো স্টার্নাল রিব, তাহলে এইটা শিখলাম। এবং এই যে 8th, 10th rib and 7th rib এর যে কস্টাল কার্টিলেজ ফর্মে আর্চ, দেখছো একটা আর্চের মতো তৈরি করেছে, হ্যাঁ, এটাকে বলা হয় কস্টাল আর্চ। সো কস্টাল আর্চ বলতেই তোমাদের ব্রেনে স্ট্রাইক করবে দিস স্ট্রাকচার, রাইট? এই দেখো 7th rib জয়েন করেছে, 8, 9, 10 7th rib এর সাথে জয়েন করছে। আচ্ছা, এইটা গেল। এরপরে যেটা বলার, এরপরে ইন্টারকস্টাল স্পেস আর দ্য স্পেসেস ইন বিটুইন দ্য রিবস। সো দেয়ার আর 12 রিবস। তাহলে হাউ মেনি ইন্টারকস্টাল স্পেসেস আর দেয়ার? কটা থাকবে? 12টা না 11টা? 11টা, কারণ 12 রিবে তো আর নিব নেই, সুতরাং দেয়ার আর 11 ইন্টারকস্টাল স্পেসেস, ওয়ান অন আইদার সাইড। সুতরাং এইটাকে বলা হচ্ছে ইন্টারকস্টাল স্পেস, ইন্টারকস্টাল স্পেস, ইন্টারকস্টাল স্পেস, ইন্টারকস্টাল স্পেস অ্যান্ড ইন্টারকস্টাল স্পেস। আরেকটা একটু বলে নেই, এই থোরাসিক কেজ ইন অ্যাডাল্ট যদি ট্রান্সভার্স সেকশন করো, it is a kidney shaped, এরকম, because of the obliquity of the ribs. In adults our ribs are oblique, upper end is above and lower end of the ribs are below. Full-on shape-টা হচ্ছে kidney shaped. But in children below 2 years the ribs are horizontally placed. So transverse section of a children is more or less circular. So in children, and a circle has got its maximum diameter on all sides, তাই তো? চারদিকেই ডায়ামিটার সমান। সুতরাং ডিউরিং রেসপিরেশন, রেসপিরেটরি অ্যাক্টিভিটি অফ দ্য মাসেলস, চিলড্রেনের থোরাসিক কেজের ডায়ামিটার আর বাড়ে না। সার্কেলের আর বাড়বে কি? ম্যাক্সিমাম তো সব দিকেই সমান। সার্কেল তো ম্যাক্সিমাম অল ডায়ামিটারস আর ইকুয়াল, ও আর বাড়তে পারে না। সুতরাং এদের মেইন চিলড্রেনের রেসপিরেশন হয় অ্যাবডোমিনাল। কি হচ্ছে? ডায়াফ্রামটা নামছে, পেটটা ফুলছে, ফলে থোরাসিক ডায়ামিটারটা বেড়ে যাচ্ছে, ফলে ইন্সপিরেশনটা নেগেটিভ হচ্ছে, এয়ার ঢুকছে। দেখবে বাচ্চাদের, ছোট্ট বাচ্চাদের দেখবে পেটটা খুব ওঠানামা করছে, কেন? থোরাক্সের ডায়ামিটার আর বাড়ছে না, বাড়ে অল্প, কিন্তু মেইনলি অ্যাবডোমিনাল। সুতরাং যদি কোনো অ্যাবডোমিনাল অপারেশন হয় ইন চিলড্রেন, দিস অ্যাবডোমিনাল movement is hampered. So you take proper precaution. Otherwise, there is a chance of accumulation of fluid in the lung in the children, leading to infection of the lung pneumonia. Sutrang after operation in children, there is a chance of pneumonia. But in adult, as there is an oblique, there is a chance of increase in diameter in all the field. So we call it in adult, the respiration is thoraco-abdominal. ক্লাসটা নেওয়া হবে, স্পেশাল মানে স্পেশালি বলা হবে, তাও বলে দিলাম। আচ্ছা, নেক্সট যাচ্ছে ইন্টারকস্টাল স্পেস। কেমন? এটা পরে আছে, হ্যাঁ। So these are the intercostal spaces. These intercostal spaces has got muscles, vessels, nerves, lymphatics, etc. These intercostal spaces, in between the spaces, this is not empty. This is full of muscles. And these muscles are attached in 3 layers. Look, these muscles are arranged in 3 layers. Arranged in 3 layers. It is the outside, it is the inner side. External intercostal, innermost intercostal, and transversus thoracis. So intercostal space is occupied, it is covered, it is occupied by 3 strata of muscles. From outside inwards, a full muscles, external intercostal, এটাকে যদি কাটো, then we see the internal intercostal, এগুলিকে কাটা হয়েছে বলে দেখতে পাচ্ছি। এই নয় যে এরকম 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 রয়েছে, পুরোটাই কভার রয়েছে। হ্যাঁ, external covers in this fashion so that you cannot see the internal intercostal unless you cut the muscle. To make you understand, it is visualized in this way. So, external intercostal, internal intercostal, and transversus thoracis. A transversus thoracis again consists of 3 groups of muscles. 3টে একই লেভেলে 3টে স্ট্র্যাটা শিখবে, আলাদা ক্লাস আছে। Sternocostallis, intercostalis intimus, and subcostalis. পরে পড়বে, আমি আর যাচ্ছি না। বুঝতে পেরেছো? আচ্ছা, এরপরে যে বিউটিফুল পিকচার, এরপরে যদি একটা নিডল আমরা যদি স্কিন দিয়ে ঢোকাই, কি কি স্ট্রাকচার পিয়ার্স করব? লাংসে গিয়ে যাবে, এখান দিয়ে ঢোকাই, ইট উইল গো টু দ্য লাংস। হোয়াট আর দ্য স্ট্রাকচারস উই পিয়ার্স? স্কিন, দেন সুপারফিশিয়াল fascia, then the muscles here, pectoralis major muscle and its covering fascia. Then we'll find these 3 groups of muscle: external intercostal, internal intercostal, and middle দিয়ে যদি যাই intercostalis intimus, আর যদি এইদিকে যাই subcostalis, আর এদিকে গেলে সরি, হ্যাঁ ঠিক বলেছি, sternocostal। ছেড়ে দাও, আমি ইন্টারনাল ইন্টারকস্টালে আনছি। কেমন? তারপরে একটা লেয়ার পাবো, সেই লেয়ারটা হচ্ছে endothoracic fascia, which covers the inner side of the innermost intercostal muscle and the bone. এটাকে বলা হয় a loose layer of membrane of connective tissue. We call it endothoracic fascia. Endothoracic fascia. কেমন? তারপরে 2টো লেয়ার অফ প্লুরা পাবো। কারণ সেদিন যেরকম বুঝিয়েছিলাম, এনি ভিসেরা যখন ইনভেজিনেট করে তখন তার প্যারাইটাল লেয়ার এবং ভিসেরাল লেয়ার হয়। সো ইট ইজ দ্য প্যারাইটাল লেয়ার অফ দ্য প্লুরা It is the visceral layer of the pleura. Then we find the lungs. Skin, superficial fascia, pectoralis major with its covering fascia, external intercostal, internal intercostal, innermost intercostal, endothoracic fascia, parietal layer of pleura, visceral layer of pleura, and lungs. These are the layers of from the skin to the lungs. And important is that, the space between the internal intercostal and innermost intercostal is intimus. This space is called neurovascular space.
Now why we do an investigation like X-ray? So some part of our body is invisible, which we do not see. Mostly this endoskeleton part, which is deeply inside, deep to skin, we do not have any clue whatsoever is happening in our body. So it's a blind process. So as an individual, whenever you are going to intervene an individual for a disease or something, we are dealing with something invisible, which you do not see. And most of the times, we are making a wild guess that perhaps this is going wrong and perhaps this is not working well. That's why this particular thing has produced. But in a modern world or modern days, we have to substantiate or we have to prove whatever you are thinking that exactly that is thing happening. So for that reason or proving what I am thinking is true or not, for the scientific reason, we have to give an evidence. Now, to produce an evidence, we have to do this procedure. We call them as investigation. This is known as the radiological investigation that we do. Took an image, say, for example, if somebody is coming with an injury, we say, "Apna hath ta geche, beshi din nahi hai." But again, you may be just like making a wild guess, may not be the case, but you have to prove it. So if a palmist, if you go, আপনার খুব ভালো সময় আসছে, প্রচুর পয়সা পাবেন, আপনার এই হবে সেই হবে, but they do not have to prove it. But what we have to do, we have to prove it scientifically, because we are people of science, though we are working on commerce and always we are working on arts. Most frequently we work on commerce anyways, but we do work this particular thing in a scientific way. So we have to prove the evidence. So we have to take a sciagram and prove it, the bone is broken. And দেখুন এই বলেছিলাম যা বলা তাই কাজ এক কথা ভদ্রলোকের. So something like that. So you have to prove it. For that we have to do the investigation. You have to take a blood test. আপনার ম্যালেরিয়া হয়েছে, কিছু উপায় নেই. So you have to prove it. You have to take a blood test. You have to show the pathogen disease which is producing it. এই দেখুন দেখা গেছে এই ম্যালেরিয়া জীবাণু এই আপনার অসুখ করেছে, এই ওষুধ খেলে সারবে. So whatever you are seeing here, you have to substantiate or you have to produce an evidence. So this is an evidence that you have to do, and this is a medical legal document. Throughout your life, you have to keep this thing. Whatever you are saying is not a bluff. You are substantiate with something, with the evidence, which is invisible part. You are making a wild guess that makes visible with this investigation, with the blood test, and this is an evidence. Based on that, you are treating. You are not doing a work service. You are giving a scientific advice based on some knowledge, which is producible and evidence proved or evidence proven matter. So this is what we are going to do about understanding the X-ray. So X-ray is basically a ray that we radiologically use to do an investigation. Now, when we do an X-ray, why we do need an X-ray? We do need an X-ray to understand a disease process. That's like what I'm saying. If the arm is broken, if you have an injury, you have to just like see the bones, see the muscles, see the soft tissue structure, if you have any problem or not. Other use of this particular X-ray or this particular radiological anatomy is that we have to do this particular thing to analyze the age of the individual. Somebody is saying, I am 12 years old. Somebody is saying, I am 6 years old. I am saying 18 years old. There is an age-limited fusions of the bone that happens at age-limited fusions of the bone. তুলে দে ওটা আর ডাকিস না ছিটকিয়ে তুলে দে age-limited evidence of these fusions of the bone that happens. Some part of the bone unites at the age of 12, some part of the bone unites at the age of the 6 or maybe 18, etc., etc. So, for example, in few days, you are going to learn this particular midline bone of the chest, which is known as the sternum. Sternum have 3 pieces of bones. We call them as manubrium, body, and the xiphoid process. Now, they are 3 different pieces of the bone. They unite at different age, 40 years of age, 60 years of age. Now, if you take an X-ray of this or radiograph picture of the sternum, you see that it is unfused. You say, this is broken. Apna sternum ta bhenge geche, dekhun, alada alada. But again, is it right? No, it is not right, because it haven't united the bhangbe ki. Jodai nahi. So you have to know that the fusions of the bone which happens at a particular age. We have learned about this particular epicondyles, medial and lateral. Medial lateral epicondyle joins with the shaft, lower end of the humerus at a particular age. Now, if you are taking an X-ray of a young kid and taking an X-ray and who has an injury in this arm region, you are taking an X-ray and saying that সব ভেঙে টুকরো টুকরো হয়ে গেছে, অনেক জুড়তে হবে. By the 6 years of this age, this particular bone never unites. This is not broken. This is not artifact. This is not you are going to unite anyways, because it's yet to unite. So you have to know that when the bone unites, or else it will be over treatment which you are going to do. আমি এমন ট্রিটমেন্ট করে দেবো সব জুড়ে টুড়ে যাবে, কিচ্ছু হবে না. So you have to know what is normal, what is not normal. For that reason, we have to do the investigations like skygram, etc., etc. So this is the use, or this is the purpose of doing it. Now, there are 2 different ways we can use the radiological thing. We call them as ionizing rays and non-ionizing rays. That means we use some ions to analyze this particular facts or skeletal or non-skeletal structures, or maybe we are seeing some non-ionizing factors which in forms of sounds or etc., etc., to analyze this. So we use ions, for example, X-ray, which is an ion which you use it. We use the fluoroscopic, which is also used as ions. We use this particular CT, computer tomogram, which is ions we are using. Compared to that, we use non-ion elements also to do the investigation, like ultrasonography. We are using the ultrasonic rays, MRI, which is like magnetic radiation, which you're using, which is not ions actually. So we may be using sounds or different wavelength vibrations to use for this particular investigation, which falls into the bigger forum or bigger category. We call them as radiological anatomy or radiological assessments. Now, largely what we have gathered today is to understand this one of the radiological anatomy, or understanding that we call them as the ionizing factor, which we commonly use at X-ray, which is a ray to interpret some of these particular soft tissue structures. So what we do, we have a kind of element, small instrument, which is actually having a filament which glows and produces this particular ion. We call them as X-ray, that is coming out of that particular machine and penetrates on some part of the body. Now, when it going through some parts of the body is absorbing it, some part of the body is not absorbing it, some part of the body partly absorbing, partly letting go. So based on that, how this particular particle is penetrating our body tissue substances, it produces an image, silhouette or chaya. So that particular silhouette, we catch it on a film, which is known as the radiographic film. And that particular film, which you see that and say that apna lymphosarcoma of the intestine, which you are seeing actually a brain specimen. So that's what we interpret. So this is how this process of ionization helps in penetrating the tissue, and eventually we are getting some kind of shadow or silhouette, and that particular silhouette we're taking it just like any picture which you are taking it. Now, this particular picture, whenever you are using it, there is a common way of using it. So whenever you are using it, this particular specimen on a radiological film or this particular radiological picture, there are 2 ways we see that. So it could be a plain skygram or plain X-ray, or it could be a spatial one. So whenever you are taking this particular X-ray machine, which is ignited, and they're taking this image, which is taking a radiographic picture, it could be a plain radiographic picture, or it could be a spatial kind of radiographic picture. Now, what is a plain and what is the spatial thing? Now, whenever you are seeing this particular, our body parts, which is like bones and the soft tissues and the organs, which are known as planes or plane X-ray or plane X-ray plates. Now, whenever you are seeing an organ or hollow organ, for example, like intestine, small intestine, large intestine, stomach, kidney, ureter, urinary bladder, uterus. So, inside cavity, fallopian tube, that inside cavity thing, we cannot see it through normal plane X-ray. So, we have to do some special procedure to visualize them. So, we have to use some substance so that this particular element glows, and when you just like throw the X-ray running through them, it picks up and becomes an image on it. That kind of image, when it is produced, we call them as spatial image. So, this particular spatial image is used for viscera. They are having a cavity inside. We call them as hollow viscera. Now, what is an hollow viscera? That means intestine, stomach, urinary bladder, gallbladder, uterus, fallopian tube, which has a lumen inside, has a cavity inside. We're seeing the cavity on it. This is where we are producing. Now, we are going to talk about this particular class. So, what is a plane X-ray? That means we are not visualizing anything special. We are not going to see anything inside. Rather, whatever it is falling on the road or whatever is falling on the way, we are taking it. So, this particular plane X-ray or plane radiogram we are going to discuss today. Now, on a plane radiogram, whenever you are seeing here the shadow, they are of three varieties. They can be white, they can be black, and they can be gray. So, the black, white, and the gray, these are the three shades that we are going to use to describe this particular plane X-rays whenever you are seeing it. So, this is the way the images we are going to see in a plane X-ray. Either these particular images or the pictures you are seeing, either this going to be black or white, or in between black and white we are going to use the word gray shades. This is one. Secondly, whenever you are going to see this particular organ, you have to just like describe which part of the organ you are seeing. Say if you are seeing this particular upper limb, you say that it is an X-ray of the upper limb or it's a radiogram of the upper limb. And what kind of X-ray that you are saying here, we will mention it, it's a plane X-ray like that. Now, there are two different ways we can see this particular organ. Either you can see face to face, just like I am standing in front of you, you are in front of me. I am throwing the X-ray from here and you are sitting in front, it is penetrating from front to back. So, that means we are throwing the light from front to back, we are getting an image on the back side, which is the shadow, which is formed on posterior to you. So, that particular view, we call them as anterior-posterior view or AP view of an X-ray. So, how these particular lights are coming and where this particular plate is taking this particular image or silhouette, that's the way we are going to interpret. AP view or anterior-posterior view. A in capital, P in capital, view is the view. Similar to that, if this particular light source is coming from the back side and this particular plate or this particular silhouette is caught on the front side, that means it's coming from the posterior side to anterior. We call them as posterior anterior view. In short, we call them as PA view. So, the views could be in front or from the back. That's the way you are interpreting. This is one way of seeing these things, AP view or PA view. Other ways, you can look it from the sides to measure the depth, how far from this particular anterior abdominal wall or posterior abdominal wall this particular structure is placed. So, for that, you take a view, we call them as lateral view. That means you are looking from the lateral sides, from the sides. So, same thing, the light coming from this right side lateral or left side lateral, depending on the side it is coming, and falling on the other side. So, if it is the right side, and this is the right side, this is the left side. So, this particular light side, you have the X-ray machine, and this side, you have this particular skiagram plate. So, it is coming from the right side and falling on this left side. We call them as right side lateral view. Opposite side, left side lateral view. So, right lateral, left lateral is a view on terms of lateral views. Thirdly, another view could be there, which is not in front, neither in the lateral side. It could be in between them. We call them as oblique view. So, that particular view we mentioned at right oblique view, left oblique view. It is coming in an oblique direction, 45-degree angle it is measured. That's why you are interpreting. So this is the way we see this particular skygram plate, how this particular images is taken, how this silhouette is made. So this particular X-ray plane plate, which is having kind of views, we call them as AP or P. You are interpreting any plate or radiographic plate, you have to go in sequence and mention about these particular things whenever you are seeing it. First thing is first, whenever you are seeing that, which part of the organ is visualized. If it is upper limb, you have to mention it upper limb. Then if it is upper limb, which part of the upper limb you have to specify. That means if it is arm, forearm, hand, or any kind of joint, if you are mentioning, shoulder joint or elbow joint or wrist joint, etc., etc. Then you have to mention what kind of view it is you are interpreting. It is anterior-posterior view or posterior-anterior view. Most of the times we see this anterior-posterior view is taken in case of this particular X-ray in the upper limbs. So the AP view of wrist joint of the right side and left side, that has to be mentioned. So right side and left side you have to mention in case of the limbs, because we have the right limb, left limb. So you have to mention right side or left side based on this. On the skygram plate, usually we have this marking on the edge as R or L. So R stands for right side, L stands for left side. So assuming that, you have to mention this is right side or left side. If you are mixed with during examination whether it belongs to right side or left side, go for these markings. Use this marking to identify it and mention about it is right side, limb, or etc., etc. This is the way we are going to interpret, going to see the things. Now, coming about the shadows, what I have mentioned. Now, some of the shadows is going to be white, some of the shadows is going to be black, some of the shadows is going to be gray. Now, how these particular shadows are produced? As I have mentioned, we are producing this particular ray, we call them as X-ray. That X-ray has a penetrable capacity. The more it is penetrable, less resistance it gets to penetrate through, it takes this particular darker shadow. So if it is passing through the lung, which is filled up with air, it has a least resistance. There are no absorption of this particular X-ray is going on. So that particular images, if it is taken on this particular tissue, which is easily penetrated, it is turning as a black shadow. So the black area is basically denoting as the air. So whenever the organ is holding this particular air, it's going to take this particular, the black shadow on the skygram plate. Now, if it is penetrating through some of the areas of some of the parts of the body, which is dense, and it produces some resistance, when it passing through that particular organ absorbs the X-ray. If it is absorbing the X-ray, it is holding it and not letting it penetrate through, it takes the shade which is more whitish. So for example, bones, cartilages, they are dense tissues. Passing through X-ray between them is difficult, and when it is passing through, the bones and this particular cartilages are absorbing it. So they are holding it back. So whenever they are holding it, they take a vivid, clear picture, and that's why this particular white shadows are usually the bones and the cartilages. These are the two elements, air which takes the black shadow and bones which takes the white shadow. Now we are left with in between character. That means they are maybe just like in between the black shadow and the white shadow. We call them as gray shadow. That means they are of medium penetrability, not as dense as the bones, neither that they are as loosened as the air. That means they have the medium penetrability, which is the muscle or soft tissue structures, the organs, the viscera, etc., which do not have the air. They have this parenchyma tissues. So this particular musculoskeletal structure, they takes this particular gray shadow. So the muscles plus organs which do not have air. So for example, liver, spleen, etc., etc., they are taking this particular gray shadows. So whenever you are seeing these plates, they are taking different shades, and you have to interpret what we are seeing here. Now, this is a normal thing that you're going to see whenever your interpretations of this particular organ or this part is going on. So, in an examination, we usually produce with a skygram plate. And when asked with the question, we ask you whether this particular plane or X-ray or this particular image is a skygram plate or spatial or plane. That's what you have to mention. It is anything special we are looking at, or it's a plain X-ray. That's what you have to make a first choice. Then if it is there, you have to mix this particular plane or contrast. That's what I am saying here. Then we have to say the view of the X-ray. That means what view we are looking at, if it is anterior-posterior or posterior-anterior view, or it is a lateral or oblique view. That what you have to next step, you have to specify. Then what region you are looking at, what part of the arm, etc., etc., or what part of this particular thorax or abdomen you are looking at. That's what you have to mention in simple words, like this is thorax, this is abdomen, this is upper limb, then this is arm, forearm, and hand, etc., etc. And then what you are seeing here within this particular skygram plate. So let's project this particular thing in the shoulder region. This is a skygram picture which you're seeing here involving the shoulder region. So whenever you are interpreting this, you have to analyze one after another. So we have to analyze thing. What's the first thing first? It is a plain X-ray or a spatial X-ray? Plain X-ray. What region you are looking at? Shoulder region. What view you are looking at? Anterior-posterior or posterior-anterior or lateral? You have to specify. Then you have to go for what you are seeing in this particular region. In the shoulder region, you are seeing here white shadow as, gray shadow as, black shadow as, if they are present. So start with any of these elements, what you are seeing here. So for example, showing what shadow? White shadow of what you are seeing here. Let's give it a try. What you are seeing as a white shadows? Bones. Now you specify the name of the bone. Humerus. Now you specify which part of the humerus you are looking at. All right, head of this. Anything else? Head and neck. Anything else? Upper part of the shaft is visible or not? You mention it. If it is visible, you say that it is the upper part of the shaft visible. Not visible, not saying. What else you are seeing other than humerus? What else, any part of the bone you are seeing here? So, clavically you are seeing? Clavically you are seeing. What part of the clavicle you are seeing? Medial part or lateral part? Exactly, lateral part showing this. Scapula you are seeing? Not seeing. Scapula not visible. Ribs you are seeing? Alright, parts of the ribs you are seeing. Right? So that's the way you are going to interpret each soft tissue structures or the bony structures, etc., etc. Then what you are seeing here, any joint is visible on this region? Then you have to mention the joints which is visible in here. Shoulder joint, which is a part of the shoulder, glenohumeral joint. Anything other than this shoulder joint which is uniting you over here, sternoclavicular joint, etc., etc. So this is the way you have to interpret. We are given this particular normal X-ray so far, whatever you are going to see, and whatever the elements we are seeing, that's what you have to narrate. So, first thing first, what kind of X-ray plate you are looking at? What are the views? What region you are looking at? What are the structures you are looking at? Bony and soft tissue structures, blah, blah, blah. Bony soft tissue structures, along with that, joint visible or not, that you have to make in mind and mention it. So whatever you are seeing it, you have to produce it. You just don't overestimate or over-imagine things. যা দেখা যাবে সেটুকুই বলবে, বেশি কথা বলতে গেলে মুশকিল, right? So moved into next part. This region, same formula. What part you are seeing here? Is plain X-ray or spatial X-ray? Plain X-ray, plain X-ray. All right. Then next, what view? Anterior posterior or posterior anterior view. You make a mind this particular view is seeing, showing what region? Elbow joint region. Now, if this particular elbow joint is there with these marks on it, right or left, you mention this is right side elbow. If it is not mentioned on this R or L on it, you just do not mention it. Unless until it is mentioned on the marking over here, R or L on this particular skygram plate, you just do not want to mention or do not go in mentioning it like whether it is belong to right side or left side. All right. Next, what we are seeing here, the parts of the bone, you mention lower end of the humerus, upper end of the radius and ulna, and which specific part, head or neck, etc., etc. Whatever you are seeing here, that's what you have to mention, and this is what expected out of it. So this is the bony shadow which you are seeing here, and this is what we are seeing here in terms of this particular region, elbow region. Similar to that, we have this particular other thing. So again, same thing. Plain or spatial? What view? Region? If it is mentioned right side or left side? R or L mentioned here? Alright, don't comment then. What showing what? White shadow of carpal bones. That's the same. Now, this is the most frequently used joint whenever you are using it. This is the most frequent used X-ray whenever you given in exams. What you are asked over here, whenever this particular specimen is given to you, we ask the carpal bones and mark the carpal bones. We put a mark any of these carpal bones and ask you mention the name of this carpal bone. So you have to know what is the proximal row carpal, what is the distal row, and how medial to lateral they are placed, and how in the skiagram plate you are interpreting it. So you have to identify this particular thumb side, you have to identify the pinky side. Based on that, you have to identify the proximal row, distal row, and orient it medial to lateral, lateral to medial, and etc. And then you have to find it. So this is the way we test this for examination, giving with these skiagram plates. Clear? Now, why we should be doing this? If you know this what is normal, then we can identify what is not normal, like this or like this. What is this problem with? Fractured clavicle. Which part of the clavicle is fractured? Shaft region. Like. So once you have mastered the normal thing, you can identify this abnormal thing based on this what you are looking at. But in examination, we are not going to give you this kind of X-rays to identify the abnormal or diseased X-ray. We are going to give this X-ray like this or this. So, X-ray or radiological image, we are going to give you either in the form of two elements. This is what we are going to talk about. This plain X-ray. There are other X-ray, we call them a spatial X-ray. What is spatial X-ray? If you are seeing something very special, then we call them a spatial. When it becomes very special, you are going to see some inside detail of it. Any organ, if you are seeing really detail, which do not have any understanding yet, that makes this thing special. To see something special, you have to be special. That means you have to add something special, then it becomes very special. To see something very special, we have to add some dyes, which is fluorescent dyes. Either we have to inject through these particular veins, or we have to swallow or take this, or put it inside somehow, inside that particular organ and take a picture. Then that particular picture makes this particular skiagram plate as a spatial X-ray. If you, in an X-ray, if you are taking it from my abdomen, it will be either the shadow we are going to get this as the gray shadow, black shadow, and the white shadows. These are the three things you are seeing here. You are not going to see any organs. Can you see any muscles in here? You cannot see here. So why you are not seeing any muscles in here? You are seeing any blood vessels in here? We are not seeing any blood vessels here. So if by any chance, if you are seeing any artery in this particular X-ray, you're seeing that some kind of artery or veins is visible in this X-ray, then that particular X-ray will be a spatial X-ray. A spatial X-ray of the same region you will be narrating in the shoulder region, showing, say for example, brachial artery or axillary artery, etc., etc., or branches of it. Make sense? So what is a spatial X-ray? What is a plain X-ray? Now for this class, we are restricting it for these X-ray, which is the plain X-ray or general X-ray, which is taken from three common views: anterior posterior, posterior anterior, lateral view, or oblique view. Based on that, it could be right side, left side, unless until it is mentioned on this particular plate. If it is R or L, we are not going to mention the side of it. Even provoked, we are not going to mention it. If they are provoking, which side it belongs? Dekhe to mone hocche right side eri, bolo na konta, bole dao na right side eta. You just like say, if it is not mentioned on the right or left, I'm not going to comment unless until I see this particular procedure going. Sheta comment korte jabo na. Why it is a blunder? So if you are commenting, this is belong to the right side, and if it is actually taking a different view, which is not all the time visible, maybe posterior anterior view is taken and you are interpreting as anterior posterior view, and it is possible in a biological symmetrical organ which looks like similar. So you may be just giving an X-ray interpretation which is broken arm on the right side, which actually having broken on the left arm, which could be a wrong thing, right? So বাঁ হাতে প্লাস্টার করে ছেড়ে দিলে ডান হাতটা ভালো থাকলো, That commonly happens, right? So that's the point about staying safe. So even provoke, don't fall in the trap, and don't try to be Shah Rukh Khan or somebody else during that particular interpreting a disease whenever you're treating a patient. So be cautious, because they are there to trap you. Once you in a trap, they will be getting compensation for getting you on a trap. So if you have misdiagnosed, for example, my right arm is broken and you have plastered on the left arm, I'll straight away go and find an advocate and sue you in the court, with the high court, with a compensation of 30 lakhs. And that money you have to produce, whatever the things you have earned, any Lamborghini or Porsche, whatever you have made with your hard-earned money, you are going to sell it off and pay me. So it's your choice, all right? So whenever you are just going to deal with it, be patient, and whatever you can interpret, that only you have restricted knowledge on it, you just deliver it. Elsewhere, just don't say, I'm not very sure, let me interrogate or let me look into it. All right? So this is an X-ray, that's the way we interpret in this particular upper extremity. During examination, we just like project like similar picture with the X-ray plates, which looks like very similar. And we usually use a pointer, like arrows commonly, like over here, for example, I point a pointer over here and ask you about what is this. I'm asking about basically, mention about this particular joint. And looking at it, you say that it is a fractured clavicle, then you make out how much marks you will be getting. Right? So you should be knowing the normal thing, what is expected out of it. So I am not going to ask any fracture element in this particular first prof anatomy examination. We will be asking about something about this. Say for example, this examination, we give this X-ray and ask a pointer with it. We give a pointer over here and ask this particular area forms a joint, and what kind of joint it is. Name the joint, type of the joint. That's simple. Looks simple right now, right? You will say, all right, this is carpometacarpal joint, this is first carpometacarpal joint, this is saddle type of joint. What's big deal in it? During examination, we get 30% people writing it correct. How many? 30%. So apparently it looks like sitting over here, easy peasy. Come to the examination, then we see this. All right? So this is about this interpreting or analyzing an X-ray. It's an ray which is liberated by an instrument which passes through our body, makes an image as it penetrates through. We call them a silhouette or shadow, which is captured on a plate which is holding that particular image. We interpret that particular image which is shown over here. And as these rays are penetrating, some part of the tissue is penetrating through and through. If it is not absorbing any light, if it is absorbing more light, it appears white. If it is not absorbing, it is going to turn black. And if it is absorbing mild thing, then it turns like soft tissue, which is the gray one. So this is the white one, ivory white, and this is gray shadow, what you are seeing here. And this is all black because it is having complete penetrability, because that's air. Good? We are done.
5 minutes, 1 hour, you'll be in Siliguri. What comes next? Train. Which train? Take Vande Bharat, it takes around 8 hours. Take Shatabdi, a little more than that. Take Darjeeling Mail, Padatik, maybe a little more than that. Then comes, that's rubbish. Then comes bus. Bus will take a lot more time because there will be rest stops, there will be traffic signals. So it may take around 12-13 hours. Similarly, when we talk about injury, there has been an injury and there has been a clinical manifestation. And there's a time lag in between. And so depending on the technique you use, you can make out those morphological alterations. For example, if you use a histochemical technique, if you use a technique that works at the ultrastructural level, for example, a histochemical technique, or for example, these pens are not working. For example, if you take a histochemical technique, you can appreciate the changes within minutes or hours. Because the changes have already started taking place, you are not being able to appreciate it with the naked eye. So you need to resort to various techniques to identify the changes that take place. And depending on the technique that you're going to use, the better, the superior the technique is, the faster you're going to appreciate. So if you use a histochemical technique or say an electron microscope, use an electron microscope, you can make out those morphological alterations much faster as compared to, say, histological techniques or gross. These techniques may take days to be appreciated. These techniques, for example, there is an injury to the myocardium. There is ischemia to the myocardium. The patient, there is no heart attack. There is no myocardial infarction. Only change is ischemia. The only problem that has happened is ischemia and the myocardium is affected. So what will be the earliest manifestation? It's a reversible injury. What will be the earliest manifestation? It will be cellular swelling. The earliest manifestation will be cellular swelling. Because of failure of the sodium pump, there will be influx of sodium in the cell, efflux of potassium, which I'll be explaining now. And because of influx of sodium, there will be isoosmotic gain of water. So there will be cellular swelling. Now this cellular swelling will not be appreciated grossly. This cellular swelling will not be appreciated grossly or even at the histological level. It will take maybe a day or two or maybe 3 or 4 days to appear grossly. But if you look at the same changes that occurs at the ultrastructural level with histochemical techniques or say electron microscopic techniques, you can appreciate the changes within minutes or within hours. So depending on the technique that is used, on one hand you have the injurious stimulus and on the other hand there will be manifestation. So manifestation at which level? The manifestation begins, the injurious stimuli begins at the ultrastructural level. So to ultrastructural level, to appreciate changes that happens at the ultrastructural level, you need to resort to various techniques. Irreversible cell injury, and this is an irreversible cell injury. So this blue curve, what does it represent? Biochemical alterations. This begins earliest. The biochemical alterations begins earliest, which is followed by the ultrastructural changes. The biochemical alterations and the ultrastructural changes, they are the earliest to develop, which is followed by light microscopic changes, where we use H&E stain, hematoxylin and eosin stain to identify, and then comes the gross morphologic changes, which we can make out with the naked eye. The specimen has been sent to you, and you can make out, for example, cirrhosis of the liver. You can make out during grossing, you have seen many pathologies in the organs. Okay, for example, cirrhosis or a fatty liver or say a carcinoma of the stomach, which we can appreciate with the naked eye. So those manifestations are the latest to develop. It begins with the biochemical alterations, then comes the ultrastructural changes, which is followed by light and gross morphologic changes. So there is a time lag, and which begins earliest? This changes begins earliest. These are the two changes which begins the earliest, and then comes these two changes: light microscopic changes and gross changes. So all these things can be appreciated depending upon what? Depending upon the technique that you use. So this is what I have written. There is a time lag between stress and morphologic changes, and it depends on the technique appreciated. With the superior your technique is, the easier for you to identify. Got it? And there are two types of injuries. One is reversible injury and the other is irreversible injury. So what is the earliest manifestation of a reversible injury? The earliest manifestation of a reversible injury is what? Cellular swelling. Why there is cellular swelling? There is influx of water. So what is that called? No. Huh? Effusion here. What is that called? Cellular swelling and fatty change. So what is cellular swelling? Why? Because there will be accumulation of water. So what is that particular change called? hydropic change, right? Hydropic change or vacuolar degeneration. Hydropic change. So whenever there is any hydropic change, there will be increase in pallor, turgor, and increase in the weight of the organ. And then there is another one called fatty change. Fatty change kothay hoy? In organs like liver, where there is excess of fat metabolism. Cells where glycolytic pathway is very common. For example, the liver. So cellular swelling and fatty change are the earliest. Cellular swelling occurs because of the failure of the sodium pump. There is influx of sodium, efflux of potassium, so there is isoosmotic gain of water. And fatty change. Fatty change is more commonly appreciated in organs which depend more on the glycolytic pathway, or where glycolytic pathway is active. For example, the liver. For example, the myocardium of the heart. Even in heart, myocardial cells also undergo fatty changes. So at the gross level, what you can appreciate is there is increase in the size of the organ, increase in turgor, and increase in weight. It's not tuber, it's T-U-R. I forgot to mention that alphabet. So increase in weight of the organ. Why? Because there is vacuolar degeneration or there is fatty change which will cause increase in the weight of the organ. Right? Clear? And then comes irreversible injury, which will be taught later. Irreversible injury is manifested. Yesterday I told you there are two ways to manifest irreversible cell injury. One is necrosis, the other is apoptosis. Okay? So this is a normal cell. First and foremost, it undergoes reversible cell injury. So at the ultrastructural level, at the gross level, you have made out that there is increase in the size of the organ. Fine, because there is vacuolar degeneration, there is cellular swelling. So what happens at the ultrastructural level? There is blebbing of the plasma membrane, blebbing and blunting of the plasma membrane, then swelling of all the organelles inside, swelling of the mitochondria with formation of amorphous densities, then swelling of the endoplasmic reticulum at the ultrastructural level. So till this level, this is reversible injury. So once the reversible, the injurious stimuli is taken off, is cut off, the cell reverts back to its normal shape and size, to its normal position. So basically the cell goes into a state of homeostasis. But if it progresses, if the injurious stimuli is persistent, the cell goes into a stage of irreversible injury. Irreversible injury, which is characterized by breakdown of the plasma membrane and the organelles and leakage of the contents outside, formation of myelin figures, etc., etc., whatever it may be, resulting in the death of the cell. There will be amorphous densities in the mitochondria, or everything which is present in cellular injury will increase. The same things, it will exaggerate. And the cell will go into a stage of irreversible injury, a point of no return. Clear? So this is reversible and irreversible injury. And on the other hand, there will be another form of cell death. You okay? Huh? If you want, you can take a leave. Okay. Get it. And on the other hand, there is another form of cell death, which is apoptosis, which will be explained to you later, where there is condensation of the chromatin and cellular fragmentation. The main difference between necrosis and apoptosis is that necrosis elicits inflammation, whereas apoptosis will generally do not elicit inflammation. So anyway, although this is not the topic now, we will be explaining to you in due time. Any questions from here? Or should I go? Should I go to the next slide? Huh? Huh? Pallor. Pallor mane ki? Pallor mane ki? What is the meaning of the word pallor? What is pallor means? Redness. What is rubor? Yeah, so what is pallor? Pale means whitish. অনেকক্ষণ হাত চুবিয়ে রাখবে, রাইট, জলের মধ্যে, বা অনেকক্ষণ হাত ধোবে, দেখবে কি চেঞ্জেস আসে, সাদা হয়ে যায়। কেন? Because of water. Because of water. Because of water. Doodh now, take milk and add lot of water. It gets diluted, right? Have you been to the ward? When you do for example, as a pathologist, the problem sometimes we face is, I shouldn't say this, but the fact is, suppose আজকে একটা পেশেন্টের রিপোর্ট করলাম হিমোগ্লোবিন 12, the same পেশেন্টের পরের দিন হিমোগ্লোবিন দেখা গেল 7. How is that possible? কোনো হিস্ট্রি নেই, ব্লাড ব্লিডিং এর কোনো কিছু নেই, 12 থেকে 7 এ নেমে গেল। এখানে কি হয়, অনেক সময় ইয়াং যারা নার্সেস থাকে, what they do is, instead of taking the blood from the vein, they take from the channel. স্যালাইন চলছে চ্যানেলে, হিমোডাইলিউশন, তাহলে রেড থেকে অনেকটা পেল হয়ে গেল না ব্লাডটা? সেম জিনিস, that is pallor. Clear? Okay, thank you. So I'm going to the next slide. You got it now? Okay. So what are the main targets in a cell? What are the main targets in a cell? So the mitochondria, the endoplasmic reticulum, what happened? The mitochondria, the endoplasmic reticulum, the plasma membrane, and the DNA. So these are the organelles which are most commonly affected in case of a cell injury. The mitochondria, the endoplasmic reticulum, the plasma membrane, and the DNA. So coming to the mechanism of cell injury, these 3 points must be known to you. Cellular response to injury depends on its nature, duration, and severity. Cellular response to injury depends on 3 things: its nature, its duration, and severity. For example, consider ischemia of the myocardium. Say the ischemia is for a few minutes. The ischemia is for a few minutes. There will be cellular swelling, but once the ischemia subsides, the cell will revert back to its normal. But if the same ischemia progresses, it will cause irreversible death of the cell. So cellular response to injury depends upon its nature, nature ta ami aschi, duration and severity. Okay, for how long, for how severe it is. Myocardial infarction doesn't happen all of a sudden. I told you there will be formation of collaterals. If the main arteries are involved, if there is blockage of the main arteries supplying the heart, there will be formation of collaterals. The blood will be supplied via collaterals, and once even the collaterals fail to function, that's when the patient will present with a heart attack, a myocardial infarction. Okay, next one, consequences depend upon the type, state, and adaptability of the injured cell. What does it mean? What does it mean? Say, for example, neurons, say myocardium, and say striated muscles. Out of these 3, which is the most vulnerable to a injury, and which is the, say, hypoxia. Let's consider hypoxia. So if we consider hypoxia, and if we take 3 states, 3 cells, neurons, myocardium, and striated muscles, which is the most vulnerable to cell injury? Which is the most vulnerable? Which one will die first? Neurons. Maybe 3 to 5 minutes maximum. Right? The neurons will die. Which is followed by myocardium. Right? Maybe more than, maybe this will go in hours. And striated muscle, exactly I don't remember, more than hours. Maybe days also. So consequences depend upon the type, state, and adaptability of the injured cell. Neurons are the most vulnerable to any kind of injury because they cannot adapt. They cannot adapt. মাথা ঘুরছে তোমার প্রচন্ড, ইস্কেমিয়া হয়ে গেছে. These cells are the most vulnerable, which will be followed by, say, myocardium, and then the striated muscles. Right? Correct, you got this point. And finally, various biochemical mechanisms. Cell injury also depends on various biochemical mechanisms which acts on various cellular components. Aschi ami point hai. So is this slide clear? So these 3 points you must remember. Cellular injury depends upon the nature, duration, and severity. Cellular response to injury depends upon the nature, duration, and severity of the injurious stimuli. Then consequences depend upon the type, state, and adaptability of the injured cell. And finally, various biochemical mechanisms, manifestations will be after various biochemical mechanisms which act on various cellular components. Okay. Now coming to the first point, ATP depletion. ATP depletion. So what is the most important mechanism of energy in our body? What is the most important mechanism of energy production in our body? Oxidative phosphorylation. Your knowledge is more than me because you're fresh from biochemistry. You should be teaching me rather than me teaching you. So your most important mechanism is OP, oxidative phosphorylation. Now, for example, say oxidative phosphorylation ceases. What is the next one? The oxidative phosphorylation of ADP is done. We are not talking of oxidative phosphorylation now. Now we are talking of an alternative pathway. The most common is ATP, your oxidative phosphorylation of ADP. Next one is glycolytic pathway. Correct? Glycolytic pathway most commonly are happening in the liver. How does a cell generate energy via the glycolytic pathway? How does a cell generate energy via the glycolytic pathway? Anaerobic. Yes. Okay. Ki kore hote pare? By hydrolysis of glycogen. To glycogen hydrolysis kore, they derive glucose. So which enzymes are involved? Which enzymes are involved in glycolytic pathway? Phosphofructokinase and phosphorylase, right? Most probably these two enzymes, phosphofructokinase and phosphorylase. Okay. So depletion of ATP কেন হতে পারে? One is reduced supply of oxygen and nutrients. There is reduced supply of oxygen and nutrients like in ischemia. Then there is mitochondrial damage and action of various toxins. For example, carbon tetrachloride. So depletion of ATP to less than 5 to 10%, depletion of ATP to less than 5 to 10% of its normal has deleterious effects on the cells. Just 5 to 10% of its energy supply is cut off and there will be deleterious effects on the cells. So what happens? For example, the ischemia and there is mitochondria. It has affected the mitochondria. So there is reduction in oxidative phosphorylation. There is reduction in oxidative phosphorylation. So there is reduction in oxidative phosphorylation. তাহলে কি হতে পারে? Reduced synthesis of ATP. Reduced synthesis of ATP. তাহলে কি effect হতে পারে? So there is ischemia affecting the mitochondria. Why mitochondria example দেওয়া হয়েছে? Because mitochondria তে maximum respiration, cellular respiration takes place, right? So there is reduced oxidative phosphorylation resulting in reduced ATP. তাহলে এই পয়েন্টগুলো clear? Right? What will be the consequence of reduction in ATP? One is there is failure of the sodium pump. There will be failure of the sodium pump. So if there is failure of the sodium pump, which I have just explained few minutes back, there will be influx of sodium and influx of potassium. So and influx of calcium, water and sodium. Obviously, when there is sodium influx, there will be more influx of water. Sodium will absorb water. Sodium will absorb water and there will be efflux of potassium. Potassium বেরিয়ে যাচ্ছে, sodium ঢুকছে. So sodium ঢুকলে কি হচ্ছে? There is isoosmotic gain of water, resulting in what? Cellular swelling. Cellular swelling. তাহলে তার ultrastructure level কি হবে? There will be swelling of the endoplasmic reticulum, swelling of the, there will be loss of microvilli and blebs. So there is overall cellular swelling because of isoosmotic gain of water. Okay, that is one. What is the next one? What is the next one? Now, oxidative phosphorylation has ceased to exist. The body has to produce energy via hydrolysis of glycogen from the peripheral stores. There will be increase in glycolysis. Anaerobic respiration বেরিয়ে যাবে. Aerobic respiration has ceased to exist. তাহলে কি হবে? Body has to provide energy somehow. There will be anaerobic respiration. Anaerobic glycolysis. So anaerobic glycolysis হলে কোথা থেকে energy source টা আসবে? Glycogen. So glycogen stores will be depleted. glycogen stores will be depleted. That's why the patient becomes thin and emaciated. Patients after a particular time report, patient starts getting thin and emaciated. This is the reason. Decrease in glycogen content of the body, and there will be decrease in the pH. The pH will become acidic. This will result in clumping of the nuclear chromatin. This will result in clumping of the nuclear chromatin. মানে এবার নিউক্লিয়াসটা affected হয়ে গেল. And the other effects include there will be detachment of ribosomes. So if there is detachment of ribosomes, তাহলে কি হবে? Ribosome কি synthesis হয়? Protein. So basically the backbone of the cell is being jeopardized. The backbone of the cell is being jeopardized. So it will be the reduction in protein synthesis, and also there will be some unfolded protein response. There will be unfolded protein response, and there will be increase in lipid deposition. So this is how তোমাদের এই জিনিসটা মাথায় রাখতে হবে. If there is ischemia, say the cause of cell injury is ischemia, the most important organelle that is being affected is the mitochondria. So mitochondria কি function হচ্ছে? If mitochondria is affected, the first and foremost thing that you have to remember is there is failure of the sodium potassium pump, resulting in influx of sodium. So there is isoosmotic gain of water and influx of potassium. So if there is isoosmotic gain of water, what will happen? There will be cellular swelling. That is one thing. Then there will be, when there is decreased ATP, the body has to be provided with energy from somewhere. What is that somewhere, and what is that source of energy? The source of energy will then be glycogen. Glycogen stores will be reduced. And finally, there will be detachment of the ribosomes, the polysomes. The ribosomes are the organelles where maximum protein is synthesized. So when there is a jeopardy of the ribosome, this will cause what? This will cause failure of the protein to be synthesized. There will be decrease in protein synthesis. There will be increase in lipid deposition. Very simple. If you study this, you can write everything. You don't need to write history. If you write this, that is more than enough, because examiner will never be in a mood to see what theory you have written. So the more you represent with a flow chart, the more you represent your answer with a diagram, tables, that has any day higher impact, far higher, far superior impact as compared to writing everything point wise. You write 60-70% like this compared to 90-95% everything without putting headings and underlining the important points, like a literature, how it is written in a literature. No one's interested to read that. You have to represent, because you're studying science, you have to represent yourself in a very scientific way. Clear? That's how you should go ahead. Cytoplasm can induce cell death. So what can happen? What can happen? One is decreased ATP production, and when there is any injury to the mitochondrium, they form certain pores. Inside the mitochondrium is sequestered certain enzymes called cytochrome. Have you heard of this enzyme cytochrome? Yes, cytochrome. And as well as caspases. Caspase, have you heard of caspase? Any enzyme called caspases? They are involved in what? If they are released into the cytoplasm, they can cause cell death. Caspases are involved in apoptosis. Okay. So one is this, when there is any injury to the mitochondrium, this is the mitochondrial membrane, and because of injury, there is certain pores in the mitochondrial membrane. Certain pores form. These are called mitochondrial permeability transition pore, MPT, mitochondrial transition permeability pore. There is, think of a mitochondria and think there is an injury. Think of a wall. Think of a wall, this wall, and say a car rams into it. A car rams into it. What will happen? It will break. It's a big wall. That's a massive wall. And the car rams into it. The whole wall won't break, but rather a part of the wall is going to collapse. Consider a dam which is holding water, and there is a hole in the dam. So what will happen? Water will start seeping in. Similarly, mitochondria, in the mitochondrial membrane, because of injury, a pore forms. Don't use the word hole and all. use the word pore, MPT. It is called MPT, mitochondrial permeability transition, MPT pore, mitochondrial permeability transition. So through that pore, cytochrome C leaks out, and also other pro-apoptotic proteins leak out. So when this pro-apoptotic protein leaks out, it causes havoc in the cell. It causes havoc in the cell. So this pro-apoptotic protein, cytochrome C, and various pro-apoptotic proteins, when they leak out, they automatically, they inhibit or they counteract the anti-apoptotic proteins. So the cell slowly but steadily moves in a direction of apoptosis, which is a form of cell death. Is this point clear? So when after the mitochondria, I have explained to you about the oxidative phosphorylation, the glycolytic pathway, ATP production, sodium pump. That is not enough. You need to know other functions also of mitochondria. Mitochondria is a place of ATP generation. So there will be decreased ATP synthesis, that is gone. But there will be pores in the membrane of the mitochondria, which is called mitochondrial permeability transition, MPT, MPT pores. So through this MPT, what will happen is, through this MPT, the cytochrome C and other pro-apoptotic proteins will leak out into the cytoplasm. So when pro-apoptotic proteins leak out, they will cause havoc in the cell. They will pave the cell towards the direction of death via apoptosis. Pro-apoptotic proteins involved in death via apoptosis. Clear? Clear. So this is gone now. Coming to the next one. If that was mitochondria, which structure is this? Sorry. This is an endoplasmic reticulum. Right? This is an endoplasmic reticulum over here, and there is a mitochondria over here. So there will be increased influx of calcium from the mitochondria and endoplasmic reticulum into the cytosol. Generally, intracellular calcium stores are very less, maybe 0.1 micromole as compared to extracellular calcium or cytosolic calcium, which is at a much higher concentration, 1.3 millimole. So when there is damage, there will be a flux of calcium from the cellular organelles into the cytosol, which will result in increase in cytosolic calcium, which will result in increase in cytosolic calcium. So increase in cytosolic calcium will activate various enzymes. Increase in cytosolic calcium will activate various enzymes. Which enzymes are activated? ATPase, protease, endonuclease, phospholipase. So what are the functions of this? What will phospholipase do? These enzymes are activated. So what will phospholipase do? They will break down the phospholipids. What will protease do? What will protease do? Protease will break down the proteins. There will be disruption of the cytoskeletal proteins. Means the backbone of the cell is basically jeopardized, it's gone. The endonuclease will have deleterious effects on what? The nucleic acids. The nucleus, sorry. The endonuclease will have deleterious effects on the nuclei of the cell. So there will be damage of the nuclear chromatin. ATPase will cause decreased ATP production. So all these things work hand in gloves. They work hand in gloves in causing death of the cell. Devastation, absolute devastation. Is this point clear? See, don't just read the theory. See the diagram and try to explain. It becomes very easy. Remember, intracellular calcium is at a very low level, 0.1 micromole as compared to cytosolic calcium, which is at a much higher level, 1.3. So, in case of any injury to the cell, this calcium will, excuse me, this calcium will come out of the cellular organelles and there will be further increase in cytosolic calcium. So, cytosolic calcium will activate various enzymes like ATPase, phospholipase, protease and endonuclease. So, each of these enzymes have specific functions. So, when they are activated, what will they do? Endonuclease will damage the nuclear chromatin. The nuclei is jeopardized. The phospholipase will have effect on the phospholipids. The protease will have effect on what? The proteins. And then ATPase. ATPase will cause decrease in ATP production. So all this ultimately culminates in causing death of the cell. So now you know there are three things: ATP depletion, mitochondrial dysfunction, and calcium derangement. And the final one is oxidative stress, free radical formation. What is basically oxidative stress? What are free radicals? What are free radicals? Free radicals are chemical species these are all paired electrons. These electrons are paired, whereas this electron is unpaired. So free radicals are nothing but chemical species which have a single unpaired electron in its outer orbit. Free radicals are chemical species which have one single unpaired electron in the outer orbit. Okay. So energy released because of this unstable configuration, reacts with the cellular components. Energy released because of this unstable configuration reacts with various cellular components like the proteins, the nucleic acids, the carbohydrates, the lipids, etc., etc. And the one thing about free radicals is when they activate one molecule, it automatically cross-reacts with the adjacent molecule. So basically a chain reaction starts, wherein when one molecule is activated, it automatically activates the other molecules. So that chain of reaction happens. So free radicals generally, free radicals are formed during normal respiration, during normal mitochondrial respiration, but our body has enough scavenging mechanisms to destroy the free radicals. It's only when the offending mechanisms win over the scavenging mechanisms are jeopardized to such an extent that the free radicals starts accumulating in the body. That's when we get this oxidative stress. So what is this ROS, reactive oxygen species? What are these? These are oxygen-derived free radicals. These are nothing but oxygen-derived free radicals, which are seen in cellular aging, cancer, various chemical and reperfusion injury, and radiation injury, and also by microbicidal killing of phagocytes. The leukocytes, for example, the neutrophils, the macrophages, when they react and kill microbes, that's when a lot of free radicals are generated. And as I have mentioned, free radicals, they form during normal respiration also, but we have enough scavenging mechanisms to destroy the free radicals. That's why we do not get this oxidative stress. Only when the scavenging mechanisms are jeopardized to such an extent that the free radicals, the reactive oxygen species, they start accumulating in the body. That's when we get various oxidative stress. For example, this is implicated in cellular cancer, cellular aging, in various ischemia, reperfusion injury, chemical and radiation injury, and various degenerative diseases, various degenerative disorders. For example, Alzheimer's. Have you heard of Alzheimer's? It happens in Alzheimer's disease also. Okay. So this is exactly what I have mentioned you in the mentioned. So generation of free radicals. The first and foremost is reduction oxidation reactions. Reduction oxidation reactions. Excuse me. So during reduction oxidation, just remember the names. Don't need to know the mechanisms in detail. In reduction oxidation reactions, what happens is there is formation of, depending on the number of electrons transferred, generally 4 electrons are transferred from oxygen to hydrogen to form 2 molecules of water. Generally, 4 molecules of O2 are transferred, 4 electrons are transferred from O2 to hydrogen to form 2 molecules of water. That happens in oxidation reduction reaction. Now, depending, sometimes instead of 4, just 1 electron is transferred. That's when we call superoxide anion, O2 minus. Then you get, if 2 electrons are transferred, we call it hydrogen peroxide, H2O2. Then sometimes 3 electrons are transferred. That's when we call OH minus, hydroxyl radical. So superoxide anion, hydrogen peroxide, hydroxyl radical, they are all examples of free radicals. Depending on the number of electrons transferred, 1, 2 or 3, various free radicals are formed. Okay, normally this oxidation reduction reaction ki hocche? Water form korche. Hydrogen and oxygen react to form water. But sometimes there may be 1, 2 or 3 electrons transferred. Depending on the extra electron that is transferred, we get various compounds like superoxide anion, hydrogen peroxide or hydroxyl radical. Right. Then absorption of radiant energy. What kind of radiant energy do you expect? Ultraviolet rays, X-rays. That is number 2. These are all how free radicals are formed. Inflammation. Inflammation, rapid bursts of inflammation. During any kind of inflammation, as someone has mentioned, what are the cardinal features of inflammation? Can anyone tell me? Physiology te porecho. What are the cardinal features of inflammation? When you said pallor, you said something else before pallor. Rubor. What is rubor? Redness. Then calor means temperature. Okay, we know it. Very good. Then dolor means pain. Then tumor means swelling. So rubor, dolor, calor, tumor. These 4 are the cardinal features of inflammation. Nothing to do with this. So there is inflammation. So in inflammation, these neutrophils, macrophages, they come into action and they release a lot of this free radicals. They generate a lot of free radicals because they kill the offending agent. And during the process, they also die. Okay. Then transition metals like iron and copper. Transition metals like iron and copper, there's a reaction called Fenton reaction. You know it. Have you read in biochemistry? You know more than me. Fenton reaction, not getting into the details. Nitric oxide. Okay. And finally, enzymatic metabolism of various exogenous chemicals or drugs. Exogenous metabolism of exogenous chemicals or drugs, or exogenous drugs or chemicals. So these are the mechanisms by which free radicals are generated. These are the mechanisms by which free radicals are generated. Reduction oxidation reaction, absorption of radiant energy like ultraviolet rays, X-rays, inflammatory reactions, transition metals like iron and copper in a reaction called Fenton, the Fenton reaction, then nitric oxide, and finally enzymatic metabolism of exogenous drugs or chemicals. These all can help in generation of free radicals. Okay. How to remove free radicals? How to remove free radicals? Antioxidants like vitamin A, vitamin E, the lipid-soluble vitamins. Then ascorbic acid. They can all release free radicals. Ascorbic acid, kothay maximum ascorbic acid thake? Source of vitamin C. Kothay thake? Top ফলের মধ্যে, like oranges and all, lime and all. That's why we always prescribe a lot of these fruits. Fruits এর মধ্যে প্রচুর antioxidants থাকে. Correct? Then, if Fenton reaction, iron and copper are involved in Fenton reaction, results in the formation of free radicals, there's a way to deal with it. There's a way to deal with it. How do you deal with iron and copper? Reduce them back how? Storage and transport proteins. Iron, copper, storage and transport proteins like transferrin, isn't it? Lactoferrin, ferritin, cellular plasmin, they can all bind to iron and copper and reduce their levels, isn't it? If iron and copper are involved in free radical generation, how do you stop them? How do you stop a criminal doing the crime? By catch hold of him and putting him in prison, right? Similarly, if iron and copper are criminals, there's a way to deal with criminals. So what are those, who is going to save them? Who is going to save you? Who is going to act against those criminals? Who is going to have an antagonistic effect for this iron and copper? The binding and the transport proteins. Transferrin, lactoferrin, ceruloplasmin. Ferritin, sorry. So these are the transport and binding agents of iron and copper. Right? Then various enzymes like catalase, superoxide dismutase, glutathione peroxidase. These are all the enzymes which can reduce the formation of free radicals. But the crux of the matter is free radicals will generate only when these scavenging mechanisms, their levels come down and the generation of free radicals is increased. Normally, free radicals are scavenged because of our effective scavenging mechanisms. But when the scavenging mechanisms are jeopardized to such an extent where free radicals keep on generating, that's when you get oxidative stress. And it is implicated in various forms of problems in the body. For example, cellular aging. Cellular aging is, shouldn't say it's a problem, it's natural. But cancer, yes. Oxidation, your chemical and radiation injury, ischemia, reperfusion injury, microbial killing of phagocytes, that is also natural. And then finally, in some degenerative diseases, for example, Alzheimer's disease. Okay? And finally is a membrane damage. I'm not explaining this slide anymore because it has been explained. If you look at this diagram, you can make out what exactly is meant here. Isn't it clear? I hope this should be clear. I'm not explaining, just giving you two examples. Finally, the damage to DNA and proteins. This is also clear. Okay, so clinico-pathological example, just remember the names. Ischemia reperfusion injury, that is one, because of massive influx of calcium into the cells. Massive influx of calcium into the cells, and how calcium has deleterious effects. It will activate various enzymes, ATPase, phospholipase, endonuclease, proteases, etc. Right. Next comes ischemia reperfusion injury. Ischemia reperfusion injury is because of generation of ROS, reactive oxygen species, and NOS. Inflammation, and there will be activation of complement. A জিনিসগুলো complement key, it will be taught to you during inflammation. I'm not getting into the details of complements now. So ischemia and hypoxic injury, remember that. Ischemia reperfusion injury and chemical injury. These are three clinico-pathological examples you need to remember. Ischemia and ischemic and hypoxic injury, ischemia and reperfusion injury, and finally various chemical injury. Okay, so this finishes the topic on cell injury.